A very good evening and warm welcome to the Kfog Edge webinar series, the third one in the series. The theme being optimizing outcome in high-risk pregnancies. This is a venture, a brainchild of our own president, Dr. Kunjumaideen of Kfog. And this time it is hosted by Calicut ONG Society associated with the other societies, that is the Perintalmanna, Waynad, Malappuram and Calicut Society, and also the Kannur Society. Kasargod Society also. So respected President and Secretary Kfog, presidents of all the societies, guests of the day, Dr. Charmila Ayavu. She is the Vice President FOGC. And we have been seeing her very much in the webinar during the COVID season. She was very active. So I welcome, it's a pleasure to welcome Dr. Charmila.
Thank you,
madam, to this webinar. And other guests of honor, our own Professor P.K. Shegaran sir, patron of Calicut ONG Society, as well as past Vice President of FOGC. Welcome you, sir, for this webinar. And along with this, Dr. Omana Madhusudanan, she is the President of Waynad ONG Society. And she is also the past Vice President of Kerala Federation. I also welcome all the delegates who have joined for this webinar. So I think we will have a fruitful sharing of knowledge today. Thank you so
much. Thank you, Madam. So before starting the webinar, for the formal address by the Chief Guest, I invite Dr. Charmila Ayavu. Madam is the Vice President of FOGC and has been the chairperson of the Clinical Research Committee FOGC for the year 2016 to 18 and ICOG Governing Council member. So I request Charmila Madam to say a few words and to formally inaugurate the function.
Yeah, thank you so much, Dr. Rajesh. Thank you for the invitation. I'd like to greet the President of Kfog, Dr. Kunjumaideen, the Secretary, Dr. Subhash Malya, the President of Waynad Societies and the past Vice President of KFOG, and dear Sir, Dr. Shegaran sir, the patron of this association. And Sir is so dear to all of us throughout India. It's not only for Kerala. It's always an honor to be in a program where Sir is there. And I would like to also give my greetings to the President of all the societies who have joined today, and the committee chair, Dr. Ambujam ma'am, the coordinator of the webinar series, Dr. Suchitra Sudhir, the president of Calicut Society, Dr. Lakshmi, the secretary, Dr. Rajesh, the other presidents of Kannur Society, Dr. Geeta, Kasargod Society, Dr. Vidya, and the president of Perintalmanna Society, Dr. Kochu S. Moni. And it is honored to be invited to a webinar which is going to be on optimizing outcomes in high-risk pregnancies. A multifaceted approach, and it's definitely needed at this time because we're seeing so many of our mothers going through metabolic problems. And the topics which have been taken today, Dr. Suma Vishnu is going to talk on the outcome in ART pregnancies, the screening and predictions of preeclampsia has been done by Dr. Sumalika, and the optimizing perinatal outcomes in diabetes by Dr. Ramya, and Doppler and FGR by Dr. Archana. All very, very relevant topics, very much needed for at this point of time because we're seeing so many mothers going through all these metabolic issues during pregnancy, and even preconceptionally, they're suffering from these diseases. And also like to welcome all the chairpersons for the day, Dr. Raghavendra Prasad, Dr. Priya, Dr. Kochumani, Dr. Hari Prasad, Dr. Jyoti, Dr. Shobha Kumar, Dr. Vinaya Chandran, and Dr. Jaya. Thank you so much for inviting me, Dr. Rajesh. It is an honor to be in a Kerala program because we know that maternal health is looked after the best in the country by Kerala. And we need to learn so much from the work that has been done, which a collaboration between the public and the private sector is not so well done in other states as it's being done. And we know this collaborative effort is a reason why maternal mortality is so less in Kerala compared to any other state in the country. And it's almost in par with the developed countries. And this will be a great learning experience for any junior who's joining the program. And I would like to thank the President and Secretary of Kerala Association for giving me this opportunity. Thank you so much.
Thank you, Madam. Thank you for the kind words and appreciation. So I invite our patron, P.K. Shegaran sir, for a few words.
Respected colleagues and my dear friends, it is indeed a great initiative by the new team of office bearers of the Kfog, Dr. Kunjumoideen, Dr. Subhash, as well as Dr. Rijesh, who is academic committee chairperson of the Kfog, and also our secretary. And as Madam was telling, these four topics are very important in the day-to-day practice, both in the early detection and prevention of morbidities and mortality, both in the mother and the fetus. Like high-risk pregnancy, I think one of the very high-risk pregnancy is the IRT pregnancies. Very difficult to look after because most of them are elderly, most of them are obese, most of them may be having systemic diseases. So that is being dealt with. And the next important thing is hypertensive disorders, especially preeclampsia, which can now be predicted and may be diagnosed early to improve the outcome. And that is also being dealt by one of our junior colleague, Dr. Sonalika, who has got, after leaving me, she has got so many degrees onto her list. Congratulations, Sonalika, for that. And it adds to my prestige also. Thank you for feeling me like great with your association with me for the time being. And of course, my own students are there. Many of them are, of course, seniors and practitioners and there. We welcome all the other societies, Waynad, Kasargod, Kannur, Perintalmanna. If I'm missing somebody, I don't know. Yeah, and also Kasargod, I think, yes. So all the presidents are here and we welcome all the delegates from all the societies, and it's a combined venture being facilitated by Calicut Society, but all of us are part of it. And I think this is a great venture by the new office bearers of our Kfog to start such a webinar, and we should continue with the academic session very often so that updating is important. Whatever we learned so many years back is not going to be the truth today. So these updating sessions, which we are welcoming such webinars, and thank you again, Kunal Moideen and Dr. Subhash, for arranging such webinars. And we are all going to. So welcome all of you. And thank you very much for the initiative that you started. This is the third one. And I hope it will come very often in the near future also. We have to continue to learn. So thank you once again. Welcome all of you. And okay, good wishes for the program.
Thank you, sir. Now I request our guest of honor, Omana Madam, for a few words. Madam, hope Madam is in place with good range. Please unmute, Madam. I think Madam has no network coverage. Madam is in a travel, I guess. Before going forward, I just request Omana Madam. I request President Kunjumoideen, sir.
Yes, yes, Rajesh. Yes, Rajesh. Can you hear
Madam,
me?
please. Yes, Madam.
Yes, madam.
Hello?
Yeah.
Yes, yes. A very warm good evening to all. First of all, let me congratulate Kunjumoideen and Subhash for this very, very useful venture. I was hearing all the three Kfog series, and it is very, very useful to practicing obstetricians. Congratulations, Rajesh, for arranging this in your academic career. Let me wish all the best. I'm sure the coming topics also will be very useful. Because I'm traveling, I don't know whether the range will be on and off. Again, wishing you all the best. All the best. And I'm sure we'll all have very good take-home messages. Thank you for inviting me along with my dear sir, Shekaran sir. Thank you.
Thank you, Madam. Before going to the academic section, I request President Kunjumoideen, sir, for the President's address.
Yeah,
Good.
dear Chief Guest, Dr. Charmila, the Vice President of Foxy, guests of honor, Shagran sir, Dr. Omna ma'am, and the past president and now the chairperson of Maternal Fetal Medicine Committee, Dr. Ambuja ma'am, then the coordinator of Kfog Edge web series, Dr. Sujitra, and my dear secretary, Dr. Subhash Malia. Subhash is here? Yeah, Subhash.
Yeah.
And all the senior faculty members and delegates. This Kfog Edge web series have been planned so that all the committees will be doing at least 3 academic programs over these next 11 months. And we have already scheduled 22 such webinars, and this is the 3rd one of this series. And the idea is that all the societies will get equal opportunity with regard to the academic programs of all the committees. So that was the basic idea of organizing this web series. And apart from the physical CMEs, which we are organizing, that is Kfog Nexus CME series, that also is going on, and we have already completed 2 such CME programs. And today, today's program is a special thing that it will be dealing with the optimizing the outcome of obstetric issues. So we used to have a lot of programs on obstetric emergencies, and the topics today which we are discussing are a few of the ones which are least discussed as well as maybe neglected, because like Dr. Shagran sir has mentioned, ART pregnancies are something difficult to manage, not because of the ART, but because of the age of the patient and the apprehensions the patients will have. So we'll have all the enlightening about all these topics. And the next 2 years will be an academic extravaganza that it will be useful for all the delegates. Thank you. Thank you, Dr. Rajesh.
Thank you, sir. So few words from our Secretary General Kfog, Dr. Subhash Manja.
Respected President Kunyumudin sir, and all the senior members of the fraternity, Dr. Shekharan sir, Dr. Ambuja madam, Dr. Omna madam, Chief Guest of the Day, Dr. Charmila madam, Vice President of OPC, and all the other presidents, honorable presidents and secretaries of all the societies, past Vice President of Perintalmanna and the whole team. I think it's a wonderful initiative by our president, and this year where we have decided to take, as sir said, each zone which we divided with and faculty from every other zone. So we're good academic sessions. I'm looking forward for very good, fruitful sessions also in the future. And I request all the president and secretaries to please involve your society members as much as possible, and to please share this idea. We have also formed a Kfog broadcast group so that we can go to the last mile, where we can go to the last person of Kfog directly and tell them about the program so that they can also join here. The second program and the first program had very good number of participants. We went up to about 250. So I'm sure as the time goes by, this also will reach that particular level of 250 to 300 by the peak of the session. And I wish Dr. Rajesh and the whole team, Muja Madam, Rajesh and the whole team, the very best for your future endeavors also. Thank you very much. Thank you.
Thank you, sir. So for the official vote of thanks, I invite President Calicut Society, Lakshmi Madam.
Respected seniors and dear friends, a very good evening to one and all. It's indeed a matter of great honor and privilege to join hands with Kfog in organizing this webinar on high-risk pregnancy. So at the outset, let me extend my sincere thanks to Dr. Kunyumudin, President Kfog, who has masterminded this webinar series, along with Dr. Suchitra Sudhir, Coordinator Kfog Edge, Dr. Ambujam, Chairperson, Maternal Fetal Medicine Committee, and Dr. Subhash, Secretary General Kfog, for giving us this wonderful opportunity. Next, I would like to extend my sincere thanks to the esteemed Chief Guest of the Day, Dr. Charmila Ayavu, Vice President FOGC, for her presence and participation today. My heartfelt thanks to Professor P.K. Shekharan, Patron FOGS, and Omana Madam for your guidance and presence. Thank you. Let me extend my sincere thanks to all the presidents of the participant societies today, presidents of Kannur, Kasargod, and Perintalmanna and Waynad Society, Dr. Geeta, Dr. Puchu Esmani, Dr. Vidya Suresh, and of course, Omna Madam, for all their support and participation. My sincere thanks also to all the chairpersons of the academic sessions, Dr. Vinay Chandran, Dr. Jyoti Chandran, Dr. Shiva Kumar, Dr. Raghavendra Prasad, Dr. Hari Prasad, Dr. Jayalakshmi Suraj, and Dr. Priya. And a very special thanks to our panel of very young dynamic speakers, Dr. Suma Vishnu, Dr. Remya Binesh, Dr. Archana Sudhir, and Sonalika Suresh. Not to forget the Secretary Cox, Dr. Rajesh Revi, who has always been a huge support and coordinator of all our activities. And not last but not the least, a very sincere thanks to all our viewers who I hope will be there with us till the end. Thank you all once again and have a great academic evening. Thank you.
Ma'am, sponsors Astri also, ma'am.
Okay, I'm extremely sorry. I must thank Astria for the sponsors of today's webinar. Thank you.
Thank you, ma'am. Thank you.
Thank you, madam. So we'll go to the awaited academic session. So we have the talks on diabetes, hypertension, FGR, as well as ART pregnancies, touching almost the major crest of the high-risk pregnancies. So we'll go to our first session. The first talk is on the outcome in ART pregnancies. To chair the session, I invite Dr. Raghavendra Prasad, is the Director of Infertility and Fetal Maternal Unit, Sunrise Hospital, Kanyanad, and Executive Director of ARMC IVF, Bangalore. And sir has been a gold medalist in his postgraduate days, as well as a winner of Kalyanakutty Memma Gold Medal for the best paper of AKCOG. Is the past president of Kasargod OG Society and South Zone Coordinator of Public Awareness Committee of FOXI. I invite you, sir, to chair the session. Along with sir, we have Dr. Priya N. Madam is the pioneer setting up the fertility clinic and IVF unit in the Calicut Medical College, which is just the second one in the government sector in Kerala, and lot of papers in national journals into her credit. So I request the chairpersons to introduce the speaker for the session. Over to the chairpersons.
So we'll now go on to the talk by Dr. Suma. Can you all hear me?
Yes, madam.
Yeah.
Yeah. So Dr. Suma is very familiar to all of us. She studied in our Calicut Medical College only. She was a very sincere postgraduate, I should say. And so this topic will be like everything in and out will be covered by Suma. And and she's working in Vinayaga Hospital, their own hospital in Waynad. And she's a member of so many committees, Perinatology Committee, Clinical Research Committee of FOXI. And she's the Associate Editor of Kfog Journal 2021. So as we all know, ART pregnancies has been on the rise in the past few years. I think most of the rates of infertility are increasing, and the number of pregnancies due to ART is also increasing. And we know that these patients are quite older than the other, the normal obstetric patients, and they have a the outcome of these pregnancies, as we know, the complications like prematurity or preeclampsia is far more than the normal pregnancies. Again, because of the donor oocyte program, and also we are routinely doing a frozen embryo transfer. So all these add up to the complications. So we are waiting for you, Suma, to enlighten us on how to manage these pregnancies.
Thank you, madam. Thank you for that wonderful introduction. My slides are visible.
Yes.
Yes.
Thank you.
Slideshow.
Yes, sir. A very good evening to all. First of all, I would like to thank Kunjumoideen sir and Subhash sir for this great venture, this very informative webinar series, and definitely Lakshmi madam and Rajesh for organizing this webinar and making me a part of it. And thank you, Priya madam and Raghavendra sir for chairing my session. So my topic for today is outcome in ART pregnancies. As Priya madam already told, ART or assisted reproductive technology is on a rise in today's medical field, and ART definitely includes IVF or in vitro fertilization and ICSI and so many procedures as such. I'll come to that. And if you look into the definition of artificial reproductive technique, all interventions that include the in vitro handling of both human oocytes and sperms or of embryos for the purpose of reproduction, it is categorized under this ART. So whatever we do with the gametes or with the embryos outside the body, it is included under the category of artificial reproductive technique. So it includes IVF, embryo transfers, ICSI, embryo biopsy, pre-implantation genetic testing, assisted hatching, gamete intrafallopian transfers. All these things come under this artificial reproductive technique. So we'll just see what all are the factors affecting pregnancy outcome in ART pregnancies. So the best pregnancy outcomes following ART pregnancies, including IVF, occur with singleton pregnancies. So that is like there is a clause in that. The singleton pregnancies should start as singletons. It is not like a multiple pregnancy which have undergone a spontaneous single reduction or an assisted reduction to a singleton. Not like that. If it is a singleton pregnancy, that is the pregnancies which has got the best pregnancy outcomes following ART. So we should always follow the use of clinical pathways that maximize the rate of singleton gestation and minimize the rate of multiple gestation. That is basically a single embryo transfer. So that is the basic thing in IVF pregnancies. And when we look into the outcome of ART pregnancies, we can categorize them as pregnancy outcomes, maternal outcomes, and neonatal and infant outcomes. So if we look into the pregnancy outcome, we always have this dilemma whether fresh transfers or frozen embryo transfers are better. So when we look into the recent studies according to the up-to-date statistics, when we compare the fresh versus frozen embryo transfers, the frozen embryo transfers are better in reason with reduction in the risk of ovarian hyperstimulation syndrome. We know that in frozen embryo transfers, the uterus and the ovarian milieu is better when compared to the fresh transfers. And definitely the tubes and the uterus are normal and the risk of ectopics are also less in frozen embryo transfers. And there is definitely a decreased risk of small for gestational age and low birth weight babies, as well as the risk of preterm births in a case of frozen embryo transfers. That is particularly because of the more natural endometrial preparation prior to a frozen embryo transfer and more natural placentation that occurs with a stimulated cycle. So with the frozen embryo transfers, the risk of SGA, LBW, preterm births, everything is less when compared to the fresh transfers. But on the contrary, something which is not good with a frozen transfer is an increased risk of maternal hypertensive disorders. That is, I'll come to that later. In natural cycles, not in natural cycles, in artificial cycles of frozen embryo transfers, there is a slightly increased risk of maternal hypertensive disorders and also large for gestational age birth weight. So this is just a categorization of the pregnancy outcome in fresh versus frozen transfers. As already discussed, as told by Madam Priya Madam, the impact of advancing age, that is what creates more complications in pregnancies of IVF. So increasing age is associated with increased pregnancy complication. And if you study the impact of ART versus subfertility, what is there in that? If you study a population, there is a Finnish population analysis, and in that there is estimated differences in the birth outcome of singleton child who is conceived with ART, and they are comparing it with the normal population, then definitely the complications are more with a singleton child conceived with ART. But if you compare this singleton child with the siblings of the same couple, the risk is almost comparable or almost the same. That is, they are showing that the impact of ART versus subfertility both have almost comparable risk rather than when comparing to the normal population. So if we take pre-implantation genetic testing, which I think is very wide nowadays, PGTA, pre-implantation genetic testing for aneuploidy, the addition of this test before IVF assumes that the pregnancy loss will be reduced by screening out aneuploid embryos prior to the transfer. But at times, in 2021 meta-analysis showing that there is no much difference in miscarriage rates if we do PGTA or without PGTA if we are doing IVF. But the key point is that if you select some particular category of women who is elderly or who is having a very low ovarian reserve and you are going to do a PGTA, definitely it is going to reduce the risk of miscarriages because the abnormal embryos are more if you subjectively or categorize the women and do PGTA. And when we speak about miscarriages, spontaneous pregnancy losses are strongly influenced by the maternal age and definitely the oocyte age. If we take a donor or if you take the maternal age, if you take the oocyte age, that is the main contributory factor for spontaneous pregnancy loss rather than the real IVF or ART procedure itself. And the second thing is that If you compare the pregnancy with one fetal heart rate on early ultrasound or early loss of a sonographically identified additional heartbeats, that is spontaneous single vanishing twin or single fetal demise, in that cases there is an increased chance of low birth weight or miscarriages or preterm births rather than a singleton pregnancy. So once you have a single fetal demise or a single fetal loss in a case of twins, one possible mechanism is that placenta can get altered and the placental milieu will not be that good. That can be a contributory reason for this miscarriages or low birth weight or IUGR. So definitely again the single embryo transfer, the idea of single embryo transfer should be adopted to avoid such complications. Ectopics. As we already know, 1 or 2% of all IVF pregnancies are ectopics, and the risk is mainly dependent on the female characteristics. If you are doing IVF for a tubal factor infertility or smoking status, not that important in our community, but still the tubal factor infertility is mainly contributory to ectopic pregnancies. And in case of frozen embryo transfers or blastocyst transfers, we do 1 or 2 embryos only. In that case, ectopics are less, or the incidence of ectopics are less. And definitely heterotopics, we think that once you keep the embryo inside the uterus, then also definitely heterotopics can come in IVF pregnancies, and more common in pregnancies conceived by ART, 1 of 100 versus 1 of 30,000. So it has got a very high incidence, and the increase in risk definitely parallels to the number of embryos we transfer. If you transfer 2 or 3 embryos, there is more chance of heterotopic pregnancies. And for this, key point is that once a patient comes to you for first trimester scan after IVF conception, never forget to look into the adnexus of the patient, even though you see a intrauterine sac. And the reason for multiples, we know that IVF pregnancies has come up with twins, triplets, everything in front of us. And we are using very, very advanced techniques for ARTs or IVFs nowadays. And every embryo we are transferring is getting implanted. That is the reason we are getting more multiples now. And this increasing implantation rates have resulted in increased overall ART births as well as increased multiples. So the increased number of twins is not as such to do with ART. It is because of the increased number of embryos which is getting transferred. And some recent studies in UpToDate is telling that in twin gestations, ART does not have a direct impact on the preterm birth rate. But definitely twins has their own increased preterm birth rate, but ART does not directly impacting the preterm birth rate in twins. Monozygotics. We think that dizygotics are common. Yes, dizygotics are common in IVF, but still frequency of monozygotics is also increased in ART. A retrospective study recently reported that the monozygotic rate is 2.3% with frozen embryos rather than 3.1 with fresh embryos. So frozen embryo shows a slightly less rate for monozygotic twinning. And that can be attributed to the in vitro culture environment, extended duration of culture in day 5 or 6 embryos, and definitely the use of assisted hatching. All these can cause monozygotic twinning in IVF pregnancies. When we think about preterms and low birth weight, I already told definitely preterms and low birth weight, the incidence is very high in ART pregnancies. And the key point is that even though it is a singleton IVF pregnancy, with or without ICSI, they are definitely at a higher risk of preterm and low birth weight, less than 2.5 kg, when we compare them with a spontaneously conceived pregnancies. So when we take a term baby with a low birth weight or a preterm baby with a low birth weight, the IVF or ART conceived baby will have a slightly higher risk to have these complications when compared to the general population. If you take out the confounding factors, even though the patient is having a high maternal age or parity or gestational age at delivery, multifetal reduction procedures, causes of infertility, if you remove all these confounding factors also, there is still a higher risk of prematurity and SGA in a pregnancy conceived with ART. And it is slightly less in frozen embryo transfers. And definitely ART conceived dichorionic twins have a high risk of very preterm birth, extremely low birth weight, ICU cares, perinatal mortality, and morbidity when we compare it with spontaneously conceived twins. So why this SGA is occurring? Basically because some of the drugs can contribute to SGA. There are so many controversial studies on that. Some studies are showing that even gonadotropins can have a role of SGA in twins, and manipulation of these gametes and embryos along with the culture medium used, effect of ovarian stimulation on endometrial receptivity, all these because of the abnormal endometrium. The basic thing is that the abnormal endometrium or the abnormal placentation is causing SGA. So whatever is inhibiting this can cause SGA in an IVF pregnancy. And some treatment bias, very few studies are showing that some more intense monitoring of this IVF pregnancies because of the more concern from the side of the couple and also the stress from the part of the doctors. More intense monitoring, more frequent interventions such as higher rate of elective CS is a bit on a higher side. But if you take a RCT, it is not that clearly proven, but definitely we have to see into it. And when we go into the maternal outcomes, like hypertensive disorders, it is really a huge number, almost 50% increased risk of hypertensive disorders pregnancy, including preeclampsia in ART pregnancy. So that is, I think it is a thing to, or a point to ponder on. We should have a close watch on this IVF mothers. And definitely a meta-analysis with 15 studies is also showing the same thing. There is an increased risk of hypertensive disorders. Use of donor oocytes is associated with an increased rate, definitely of preeclampsia and hypertensive disorders. A thin endometrium, less than 7.5 millimeter prior to embryo transfer, is also having an increased risk of hypertensive disorders, probably because of the abnormal placentation. And this decreased birth weight, IG, abnormal placentation contributory factors can occur with a thin endometrium. And what is the pathology behind it? The basic pathology is that the ART cycles that retain a corpus luteum is to be somewhat protective for hypertensive disorders. That is what is the basic pathology. So if you take a frozen embryo transfer, if it is a natural cycle frozen embryo transfer, you will have a corpus luteum. So that will cause a lower rates of preeclampsia or hypertensive disorders. But if you have a medicated frozen embryo, that is a programmed frozen embryo transfer, such cycles or such babies can have an increased risk of hypertensive disorders in pregnancy. And abnormal placentation, we already discussed all the abnormal placenta related complications, placenta previa, placenta accreta spectrum, as well as placental pathology. It appears to be increased in pregnancies conceived with IVF. This abnormal placental pathology is the basis behind this abnormal placentation and all the complications related to that. And that is also slightly on a higher side in frozen embryo transfer, fresh embryo transfers. And the accreta spectrum, the placenta accreta spectrum, the IVF pregnancies, it has more than 5 times the risk of PAS when compared to non-IVF pregnancies. This is according to the recent up-to-date statistics. And this frozen embryo transfer cycles, they are associated with a decreased risk of placenta previa and abruptio placenta. That is because we are giving a good endometrial environment at the time of implantation. And definitely the absence of the corpus luteal cyst may also have a role in this. So good endometrium, good placentation, we can avoid this placenta related complication. GDM also, even though we avoid the confounding factors like PCOS, is still on a higher side in ART pregnancy. So definitely we should have a close watch on all these medical complications in a ART conceived mother. And regarding the maternal morbidities, regarding other factors rather than this medical disorders, this advancing age and pre-existing medical conditions definitely increases maternal morbidity and mortality in case of IVF pregnancies. And stroke, increased risk of postpartum stroke compared to a natural conception. So any thromboembolic phenomenon, including stroke, can have an increased risk with IVF pregnancies. And the risk factors are definitely, the first thing is advanced age, the comorbid conditions, elevated BMI, and the increasing use of frozen embryo transfer during IVF cycles. And why? Because this frozen embryo transfers, I already told, it has an increased risk of hypertensive disorders. So indirectly, it can cause an increased risk of stroke and other thromboembolic phenomena. So thromboembolism is very common in ART pregnancies or IVF pregnancies, especially during the first trimester. Also, it can occur even in the absence of an overt diagnosis of OHSS. Thrombosis can occur. But the benefits of anticoagulation need to be definitely balanced with the risk. It is not that you should give anticoagulation for each and every lady. You should calculate the benefit versus risk and categorize the risk and start on with thromboprophylaxis. So that is very important. And here comes the most dreadful scenario or most dreadful thing which we all worry about, the cancers. Is there any chance of increased risk of cancers in mothers who have conceived with IVF or ARTs? And the recent studies shows that the use of fertility drugs and IVF does not appear to increase the risk of all cancers, whether it is breast, whether it is uterus or ovarian cancer. The main thing is that the impact of infertility versus fertility therapy, that is the basic study on that. The use of fertility drugs is definitely going to cause ovarian neoplasia, or they are disturbing the ovary or hyperstimulating the ovary. But infertility, by reducing the number of successful pregnancies, in turn, a risk factor for ovarian cancer. So you have to think in two ways, whether the infertile couple, because of the infertility per se, is going to get an ovarian cancer, or whether your infertility treatment is going to get her cancer. So you have to calculate on both. When you study both these factors, it is shown that ART or artificial reproductive techniques per se is not contributory or not an independent risk factors for ovarian cancer. And similarly, the studies are showing that breast cancers are also not that much on a higher side on ART treated mothers. And so even in individuals with BRCA1 and 2 mutations, we can take them for ART if indicated. There is no exemption that they should not be taken up for ART. So this is just a 2020 cohort study. They compared 30,000 individuals who received ovarian stimulation for ART, nearly 10,000 subfertile individuals not treated with ART. So ovarian cancer risk in the ART group was elevated compared with the general population. But when you compare with the subfertile group, the risk for malignancy is almost the same. So what I meant to tell is that the infertility versus ART, you have to categorize and individualize. There is no per se risk of development of malignancies because of ART alone. So ovarian cancer risk definitely decreases with increasing parity and with larger number of successful ART cycles. I must say it is successful ART cycles, because once you get conceived or once you get successful ART cycles, the risk gradually decreases. So that is about the pregnancy and the maternal outcomes. When we go on to the neonatal and infant outcomes. So there are some risk for chromosomal and definitely genetic alterations in IVF pregnancies. There is no increase in the prevalence of chromosomal abnormalities in offspring of IVF conceived pregnancies compared with unassisted conception. But some chromosomal abnormalities in the embryo are related to the increasing maternal age per se. So maternal age is definitely causing this problem. And use of sperm from a subfertile men and the intracytoplasmic sperm injection procedure itself may increase the risk of chromosomal and gene abnormalities in children conceived by ART. ICSI may interfere with the genomic imprinting during germ cell development and pre-implantation. So per se, IVF is not a contributory factor for chromosomal abnormalities, but because of the male factor or because of the abnormalities in the embryo, they can have an increased chance of chromosomal and genetic abnormalities. And regarding the risk of congenital anomalies also, there is an increased risk or a 1/3 risk more in case of ART pregnancies. Impact of fertility, including subfertility, appear to be definitely an independent risk factor itself. And there are more chance for cardiovascular anomalies, musculoskeletal anomalies, and genitourinary risk defects in this infants with ART. So the contributory factors are definitely the age of the mother, cause of infertility, prior treatment of infertility, environmental exposures, and definitely the technique of ART. And this is the National Birth Registry data. Overall, in 2017, 68,908 single children were born by ART. There was an estimated excess of 386 born with a major birth defect. And I just want to highlight the percentage, like 18% of them have an increased risk of major non-chromosomal birth defect, that is structural birth defect. They are conceived with ART without ICSI. Once they went into ICSI, 30% increased risk of non-chromosomal birth defect is there. And with ICSI and male factor, 42% increased risk of major non-chromosomal birth defect is there. So this is the National Birth Registry data given out in 2017. So we should have a proper screening on all the IVF mothers for the probably developing birth defects. And imprinting disorders, actually the incidence of these disorders are really very less. And so we are not giving much importance on that, but there is a slight increase in the incidence of imprinting genomic defects too, maybe because of the procedures of assisted hatching and the manipulation of the embryos. And Beckwith-Wiedemann or Silver-Russell syndrome are significantly associated by IVF or ICSI. So that is also kept in our mind, but because of the very rare incidence of these disorders, absolute number is still very low. So when we take the long-term outcomes, I think this is one which every parents are much worried about. Will there be any long-term abnormal outcomes for our babies who are conceived with IVF? So outcome among ART offsprings up to 28 years of age have been reported. And they are definitely reassuring. That is a very good thing. We have not found much problems with this, and there are 28 years of follow-up with this offsprings. And a study comparing 253 ART conceived adolescents with a case match reports detected no detectable differences between the groups of general health, mental health, or cognitive ability upon review of military pre-induction screening records. So they have screened this adolescents with the control group, and they have found no significant differences between them. And I think that's a very great thing. And regarding the chronic illness in the infants, there is a slight increase in the metabolic diseases, type 2 diabetes and cardiovascular disease later in life, which is yet to be proven. Increased risk of asthma is reported in some studies. Small increased risk of neurodevelopmental problems in child conceived with ART. And there are some confounding factors on that. So it is not that well proven, only very small studies are showing this. Confounding factors are prematurity, infertility or subfertility, which may be the reason for the neurodevelopmental problems. And definitely again, the risk of cancer in offspring is also not that increased in children of IVF pregnancies. So summarizing, ART, as I already told, it includes all interventions that involve the in vitro handling of both human oocytes and sperms or embryos for the purpose of reproduction. ART has resulted in more than 8 million pregnancies worldwide. I think that is a very, very huge number. The best pregnancy outcome with IVF or ART occur with singleton pregnancies. I emphasize on that. It is singleton pregnancies which have a very good outcome. And regarding the maternal outcomes, it is almost comparable to naturally conceived pregnancies, but still there is a small increased risk of thromboembolic events, hypertensive disorders, and other medical diseases of pregnancy, age-related problems, and the evidence is reassuring that the rates of cancer are not elevated beyond the baseline risk for these infertile females. And regarding the singleton pregnancies, I told a risk of low birth weight and spontaneous preterm birth and preeclampsia is bit on a rise. So you should have a close watch on these kids. And frozen embryo transfer rather than fresh embryo transfer is associated with reduced risk of low birth weight and spontaneous preterm birth. In multiple gestation, the factors related to pregnancy with multiple gestation, they are closely related to the factors which are having which are contributory to which are having the complications of normal twin gestation only. So the twin pregnancies, they should have a close monitoring, and they will be having complications on their own, and we should have a close watch on them. And regarding the infants and children born using assisted reproductive technology, they are the outcomes are very much reassuring, and the vast majority of babies born after ART are normal. And the neonates, they conceived with ART appear to have a modest increased risk of congenital anomalies and stillbirth, and some cases imprinting disorders, but not much of chromosomal abnormalities if you take out the confounding factor of maternal age or male sperm factors. And childhood and beyond, everything is generally reassuring. The health outcomes of children conceived through ART, we have a follow-up of 19 to 28 years. It is reassuring. The neurological and pubertal development do not appear to be impacted much, and the risk of cancer is not on a rise in kids of ART pregnancies. So I must say that we should have a big thanks to these two great people, Patrick Steptoe and Robert Edwards, who have brought up this great technology to the field of medicine. And we have so many smiling faces in front of us because of this technology. So many people are growing up with kids in their hand. And thank you so much.
Thank you, Dr. Suma. Over to the chairpersons.
Thank you, Dr. Suma, for a wonderful presentation. By the end of your talk, I think most of the obstetricians will feel that we better not handle patients with IVF looking at the risks involved. But it's generally a fact because in Kerala, I think every month we are adding around 300 to 500 IVF pregnancies every month to the tally in Kerala. So definitely each and every obstetrician will end up having to manage at least 1 or 2 IVF pregnancies. And with, generally speaking, you have a lot of hypertension and diabetes occurring in these women. And definitely the NICU care for the babies are also definitely on the is required. Because most of them, quite a lot of them end up becoming premature or taken out for some other reason, maybe because of severe hypertension or diabetes. So a much well-covered subject so that it enlightens all of us, makes us aware of what to expect and what we can face and be ready to face the onslaught, you can say.
Yes, sir.
Thank you,
I
doctor.
just
It was a
want to
beautiful
emphasize
presentation.
the close monitoring of those pregnancies, sir. That is why ultimately on all the studies there is no long-term risk. We have actually a 28-year of follow, so there is no much risk for even the adolescents. So I just want to highlight the point that you should have a very close watch on those mothers.
Exactly. Yeah.
Suma, it was an excellent talk, but I just want to add one thing.
Yes, sir. Definitely.
Apart from donor oocyte, donor sperms also will increase the incidence of preeclampsia and
Okay, sir.
in these pregnancies.
Yes, sir. Okay, sir.
Another thing which I would like to add is we do get quite a number of IVF pregnancies coming for delivery to the medical college. So what we find is there is a steep increase in the incidence of periviable fetuses, babies, in the periviable gestational age, which is adding to a huge burden on the neonatologist side. So
Yes.
the long-term outcome of these infants, nobody really knows about the neurodevelopmental delay and that is infants born at around 24 or 26 weeks, because as you said, for the maternal sake, sometimes we are forced to deliver them at an earlier gestational age. So what happens to them really in the long term?
We need a
Have a
follow-up.
registry of our own, like in Kerala, like what is happening to these babies, like in the long term, what are the problems? Like we have to have a register of our own, I think.
Exactly.
And many a times we find like unexplained increase, like alterations in the liver function test also. Many patients we have found, there will be actually no explanation for that, but they, like many of the time we have to terminate the pregnancy early, like around 30-32 weeks because of abnormal LFT. Like we had our own few patients having that problem.
Abnormal LFT might just be limited to an abnormal elevation of the liver enzymes. We don't even find a complete derangement of the rest of the liver function test. Isn't that what you mean?
Yeah, that is what. Like we are scared to carry on with that pregnancy, and most of the time we end up terminating it. Isn't it,
Yeah.
ma'am? I found many cases like that.
Okay.
Good presentation, Suma.
Thank you.
Covered most of the aspects.
Thank you.
It's a very good presentation, Suma.
Yes, sir.
May I ask one not a clarification? What is the incidence of vaginal delivery in the ART series?
I don't have any data on that, sir, but I think nowadays vaginal delivery is bit on a rise. Previously, for every IVF pregnancies, we used to do sections, but now
Okay.
IVF has become more common that we are also trying for vaginal deliveries, because many
Yeah.
of the mothers are not having much medical comorbidities, because even in younger mothers, they are going for IVF because of the male factor and all. We are keeping them for delivery. So I think the delivery rates are coming up.
That's
Can I
right.
add something?
It should
Can
be
I
so.
add something? Yes. Sir, actually, many of the IVF centers, routine cesarean section is being offered at 34 weeks, even without medical complications. So
That's what I
I
did.
think that is not necessary in many of the situations, and actually we can follow up, and with any of the medical comorbidities, maybe we may have to terminate. Otherwise, they have good chances for vaginal delivery. That's what I feel, because the IVF or ART pregnancies per se is not an indication for cesarean section. That should be the norm, actually.
Yeah, it is
But
true, madam. But unfortunately, most of the mothers, when we give them the option of normal delivery, 70% of them themselves choose to go for cesarean and get the baby out fast.
Okay.
That's true. The patient's mind setup is different, and they will be sort of telling us that it is 5 years, 10 years, and I am so many years old, not to take any risk. So this sort of prompting will come from the patient side or the relative side, and that will make us to. I have done almost every case I have to do is cesarean. I can't boast of any allowing vaginal delivery, but the elderly and other complication may be indication. But just because IVF, it's not an indication for cesarean, but unfortunately, we have to yield to the pressure of the family, because even you look at the social factor and other things, we cannot take a risk. But cesarean section also has its own risk, but we can't help it. So we keep on doing. I don't know whether I read it correctly in your one of the slide that you said 36% of major anomaly or something. There may be a mistake in that slide or so.
Which one, sir?
Major congenital anomaly, structural anomalies. You have projected.
That is structural anomalies, basically
That's
more
for male factor, sir.
Yes, sir.
Male factor exceed.
Yes, sir.
Okay.
Male factor
Right.
and ICSI comes, the number of anomaly percentage is on a rise. That is what I mentioned. That is from the National Registry, Birth Defect Registry.
No, it is given as 36%. I don't know whether
Yes.
that much.
Yeah, correct. Maybe from the total birth defects they are calculating, sir.
Okay.
And also,
Because whatever we say,
Huh.
the assisted reproductive technologies are giving most of them are normal babies. We should not be scared
Yes,
of
sir.
this
Yes,
thing.
sir.
It
Definitely,
is
sir.
majority we are getting so many of the infertile couple are getting normal babies rather than
Yes.
abnormal babies. That is a
Yes,
plus
sir.
point. So we should not be carried away. It is a good option
Yes, sir.
for those people, and we are getting most of them. We have seen the anomalies and other things. I mean the aneuploidy also causing.
Yes, sir.
So now
Yes,
there is
sir.
a screening for that also. We are ruling out that aneuploidy, and then transferring is a good method to, especially when they are age related. Actually, we should have the aneuploidy screening, and also if it is pre-implantation, that is best way of screening out that. A great presentation. We have learned many things. Thank you,
sir.
Suma.
Thank you, sir. Thank you, sir.
Thank you, Dr. Suma, for that wonderful talk. And
Thank you, Rajesh.
without much delay, we'll go on to the next talk. Before that, for the delegates, if there are any queries, you can put in the Q&A session. It will be answered in the time between the talks. So next talk, we have our own Dr. Sonalika Suresh, and the topic is none other than one of the most important topic when coming to the high-risk pregnancy, that is screening and prediction of preeclampsia. So
so one international faculty.
yes, international
Yeah.
faculties.
So you invite the
So we have to
chairpersons
chair the
again.
sessions. We have Dr. Kochusmani. I think madam has not joined it. She's the president of Perintalmanna ONG Society, and I request Dr. Hariprasad sir, consultant at Lourdes Hospital Taliparamba, as well as Pastor Mims Kannur, and serve as one of the major person in formation of the Kannur Society, and regional coordinator and Asra of CRMT Kerala, captain of MDMSR Kannur. So I request sir to introduce our speaker for the session, Dr. Sonalika.
I think Dr. Pavitra has been asked to join instead of Dr. Kochu. Is Dr. Pavitra in from Maulana as a chairperson? Okay.
Good evening. Am I audible?
Yes, sir.
Yes.
Yes.
Good evening. Dr. Sonalika Suresh is a specialist at NMC Specialty Hospital, Dubai. She is a fellow of Royal College and European College. She's got a diploma in ultrasound and advanced training in reproductive medicine and laparoscopy and in gynecology. She will be dealing with the prevention and how we will screen the preeclampsia during pregnancy and how we can prevent this condition. Preeclampsia, as you all know, there is 3 to 5% of our pregnancy. There is an incidence of 3 to 5%, and we are already doing for every pregnancy the first trimester screening for Down syndrome. So compared to Down syndrome, preeclampsia is more prevalent. So in the first trimester itself, we have to do the screening for preeclampsia to everybody. That is my opinion. I invite Dr. Sonalika to present the talk.
Thank you, sir, for the kind words. First of all, I would like to thank all the organizers, Kunyamoideen sir, Subhash sir, Lakshmi madam, Rejish, Ambujam madam, for giving me this opportunity. And thank you, Hariprasad sir, for chairing this session. Actually, this was my thesis topic under the guidance of Shekaran sir. So happy for being a part of this webinar and for the topic too. So coming to my topic, prediction and prevention of preeclampsia. So preeclampsia is a pregnancy-specific disorder manifesting as hypertension and multi-system dysfunction. And we know that it is one of the leading causes of maternal mortality. More than that, it also causes significant maternal morbidity and adverse perinatal outcomes. And it is also a risk factor for future cardiovascular and metabolic diseases. So if we can predict preeclampsia at an early stage, we can provide appropriate antenatal surveillance and start preventive measures, thus we can optimize the outcomes. So the International Society for Hypertension in Pregnancy defines preeclampsia as gestational hypertension accompanied by one or more of the following new onset condition at more than 20 weeks gestation. And this new onset condition can be either proteinuria or a maternal end organ dysfunction or a uteroplacental dysfunction. And depending upon the timing of the delivery, the preeclampsia is now classified as early onset preeclampsia and the late onset preeclampsia. This classification is very important because in early onset preeclampsia, which occurs with a delivery at less than 34 weeks of gestation, and it is associated with the much higher risk of all short-term and long-term maternal mortality and perinatal morbidity. So it is the early onset preeclampsia that is associated with IUGR, abnormal uterine artery Dopplers, and also the recurrence risk of early onset preeclampsia in subsequent pregnancy is also very high. When compared to late onset preeclampsia is associated with a mild maternal disease and better perinatal outcome. And there is a preterm preeclampsia with delivery less than 37 weeks and term preeclampsia with delivery at more than 37 weeks. So the challenges are more with the preterm preeclampsia because here we have to balance the between the because here we have to balance between the maternal and the fetal risk of continuing the pregnancy with that of the fetal immaturity in utero. So the basis of all the preventive and predictive measures depends upon the pathogenesis in preeclampsia. So a few words on that. So we know that in the normal implantation, there occurs the trophoblastic invasion and the spiral artery remodeling. So this takes place in two phases. The first wave actually starts at around 10 to 12 weeks of gestation and in the decidual part of the spiral arteries. Here the cytotrophoblast replaces the vascular endothelial and the muscular lining to enlarge the vessel diameter. And the second wave starts at around 16 to 18 weeks and which transforms the myometrial segment of the spiral arteries into wide mouth vessels, which becomes non-responding to the vasomotor stimuli. Thus, the blood supply is transformed from a high resistance, low flow system to a low resistance, high flow system. But in preeclampsia, this primary wave failed to occur. Primary wave is impaired and the secondary wave fails to occur. Thus, there occurs the uteroplacental blood flow is decreased, which will lead to placental hypoxia and the oxidative, which will lead to oxidative stress and the release of pro-inflammatory cytokines and the anti-angiogenic factors like soluble FMs like tyrosine kinase and soluble endocrines, which will lead to endothelial cell dysfunction and vasospasm, which is the key feature in the pathogenesis of preeclampsia. Now, a few words about angiogenesis. The angiogenesis for the trophoblastic invasion, angiogenesis is very critical, and the angiogenic factors are the vascular endothelial growth factor and the placental growth factors. But in preeclampsia, because of the placental hypoxia, there is an increase in the anti-angiogenic factors, which includes the soluble FMs like tyrosine kinase. So there is an abnormal angiogenesis. So we have to be prepared before the lightning strikes. So how can we be prepared? So it's by the prediction of preeclampsia. According to the FIGO, there should be a universal screening. That means all pregnant women should be screened by the first trimester or combined test with maternal risk factors and biomarkers as a single step procedure. So there have been various tests for the prediction of preeclampsia. Many traditional tests have been there and number of newer biomarkers have been studied for the prediction, like placental growth factor, vascular endothelial growth factor, SFLT, soluble endoglins, many nucleic acid markers like cell-free DNA, mRNA, multiple markers have been studied. But for an ideal screening test, it should play a central role in the pathogenesis. It should be specific for the condition. It should have high sensitivity and specificity and should be easily available and it should be cheap. So, but none of these tests have been proved to be ideal. So what are the screening tools that are available? So one is the maternal risk factors. Other is the biophysical test, which include the mean arterial pressure and the uterine artery pulsatility index, and the biochemical tests like PAPE and the placental growth factor. So then according to the NICE recommendation, it only assesses the maternal risk factors for the prediction of preeclampsia. The high risk factors include the hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as SLE or APLA, type 1 or type 2 diabetes, and chronic hypertension. And the moderate risk factors include nulliparity, age 40 or older, pregnancy interval of more than 10 years, BMI 35 or more at first visit, family history of preeclampsia, and multiple pregnancy. So if the woman have any of these high risk factors or more than one moderate risk factors, it is considered at high risk, and we have to start 75 to 150 milligram of aspirin from 12 weeks until the birth of the baby. This is a NICE recommendation. So we also have the gestosis score, which also assesses only the maternal risk factors. It was developed by the Foxy ICOG Good Clinical Practice recommendation. And the score involves all the existing and the emerging risk factors in the pregnant woman. The score 1, 2, and 3 is allocated to each clinical risk factor as per the severity in the development of preeclampsia. And when the total score is more than or equal to 3, the pregnant woman is marked as at risk of preeclampsia. So this is a scoring. There are 14 parameters with the score 1 and 6 parameters with score 2 and 7 parameters in score 3. So here we have to say that IVF and ICSI pregnancy, the score is given as 1, but a pregnancy with surrogacy or donor is given a score of 3. Even the mental disorders have been given a score of 3 in gestosis. So the studies have found that the gestosis score has a sensitivity of 83% and specificity of 97% in predicting preeclampsia. So in low resource setting, this is a very good tool. So next, coming to the biophysical markers. It is a mean arterial pressure, which so while measuring the blood pressure, it has to be measured accurately. The patient should be in the comfortable at rest. The BP cuff of appropriate size should be used and it should be placed at the level of the heart. And the mean arterial pressure is equal to diastolic pressure plus 1/3 pulse pressure. And the normal mean arterial pressure is around 70 to 100 millimeters of mercury. Next biophysical marker is the uterine artery Doppler. It is a very non-invasive method for the assessment of the uteroplacental circulation. We have said that in normal pregnancy with advancing gestation, there is decrease in the resistance in the spiral arterioles because the uteroplacental blood flow increases. But in preeclampsia, because of the poor placentation, the impedance to the flow increases, and because of that, there is abnormal waveforms in the uterine artery. So, but there have been these specifications when we measure the uterine artery Doppler. A 5 or a 3.5 megahertz curvilinear transabdominal transducer has to be used, and a mid-sagittal section of the uterus and the cervical canal and the internal os is identified, and the color flow Doppler is applied to identify the uterine artery, and the pulse wave Doppler with a sampling gauge set at 2 mm is applied. But we have to make sure that the angle of insonation is less than 30 degrees to obtain the highest systolic and the diastolic velocities. So it has to be done by a trained person so that we get the optimum results. And if the uterine artery pulsatility index is more than 95th centile, it is considered to be at high risk of preeclampsia. We have to measure both the right and the left uterine arteries, and the mean uterine arteries pulsatility index is taken. Next is the biochemical markers. We have the PAPA, which has a metalloproteinase produced by the placental trophoblast. And in case of poor placentation, the PAPA is less, and PAPA less than 0.4 mom is seen in 2 to 23% of the women with preeclampsia. The other biochemical marker is the placental growth factor, which is an potent angiogenic factor, and it is synthesized by the cytotrophoblast, and it is decreased in case of preeclampsia. And it's a very good biomarker because the placental growth factor alone can detect early onset preeclampsia in 55% of the cases and late onset preeclampsia in 33% case. So if we take only maternal risk factors, the detection rate is around 40% for early onset preeclampsia. But when we take maternal risk factors with the mean arterial pressure, the detection rate is around 76%. So these two are something which we can do in routine practice. But nowadays, the uterine artery Doppler is also done along with the combined test, where if the uterine artery Doppler alone has a detection rate of 48%, and PAPA alone has a detection rate of 44% for early onset preeclampsia. But when we combine and do a combined screening with the maternal risk factors, mean arterial pressure, uterine artery Doppler, uterine artery PI, and the PLGF, the detection rate increases up to 82%. So we have the FMF algorithm, which uses the Bayes theorem to combine the prior risk from a combination of these risk factors and the biophysical and the biochemical measurements. And this is an online risk calculator, which is available free at the website. It would look like this, and we just have to fill in the details of the pregnancy type, the pregnancy dating, the maternal characteristic, the medical history, the obstetric history, the biophysical measurements like mean arterial pressure, uterine artery PI, and the PLGF value. And even if we are not doing the PLGF value, if you put it no, we can add the PAPE value and then calculate the risk. The cutoff is taken as 1 in 100. So if the cutoff is more than 1 in 100, it is screened as high risk, and we have to start low dose aspirin from 12 weeks. And if it is screened low risk, that is less than 1 in 100, the routine prenatal care is continued. A few words about the SFLT-PLGF ratio. Actually, this is more predictive of the preeclampsia onset and also the severity of the preeclampsia. And it also has a very good negative predictive value. That is, if the SFLT-PLGF ratio is less than 38, it can rule out the occurrence of preeclampsia within 1 week. And if the ratio is more than 85, it is indicative of early onset preeclampsia. And if it is more than 110, it is indicative of late onset preeclampsia. And this ratio has also have a very good sensitivity, 95% sensitivity in prediction. Yeah. So coming to the preventive measures, so we have to, so in pre-conceptionally, achieving an ideal weight before conception, we have to control the blood pressure before conception and control diabetes and stop smoking. All these are primary preventive measures for the prevention of preeclampsia. So there have been many studies which have been seen for the prevention, but only 2 drugs which have been proven for prevention is the low dose aspirin and the calcium. So coming to the low dose aspirin, it is a cyclooxygenase inhibitor which reduces the thromboxane and inhibit platelet aggregation, resulting in an anti-thrombotic effect. There are many studies which have been proved that it is safe for the pregnant woman and the baby. And with the low dose aspirin, there is no excessive bleeding during C-section or regional anesthesia, and there is no increase in incidence of abruption or PPH. So it was a class trial which was done in around 9,000 women, and the conclusion was that the low dose aspirin may be justified in women judged to be liable for early onset preeclampsia severe enough to need preterm delivery. So that means for early onset preeclampsia, the low dose aspirin is justified. And it also provided the support with regard to the safety of aspirin in pregnant women and for the baby. Now, there was another trial, which was the Aspire trial, which was done in around 26,000 women. And in this study, 150 milligram of aspirin was given to women from 12 weeks to 36 weeks at night, for those who were found to have high risk by FMF algorithm. And the study showed that the prevalence of preeclampsia in the high risk group, that is decreased the evidence of preterm preeclampsia to less than 62%. And the prevalence of preeclampsia in early onset preeclampsia was reduced to 82% and with the aspirin. So there was significant reduction in the preeclampsia within the aspirin group. So about the dosage, the RCOG recommends 75 to 150 milligram of aspirin at night daily from 12 weeks until the birth of the baby. The low dose aspirin means it is around 2.5 to 3.5 milligram per kilogram is the required dosage to produce a consistent inhibition of the platelet aggregation. And the dosage of 150 milligram per day would be sufficient for a woman with a 65 kg at booking. But the minimum dose of aspirin to be prescribed for high-risk women is shown to be like 100 milligram per day. Now, about the role of calcium. Both the FIGO and the WHO recommends that oral elemental calcium 1.5 to 2 gram to be given daily in patients whose intake of calcium is deficient. If the deficiency in calcium is considered as if it is less than 800 milligram per day, considered to be deficient in calcium, and in those cases 1.5 to 2 gram can be given to reduce the risk of preeclampsia. And if we are giving this high dose, it has to be given in divided doses, where the dose of less than or equal to 500 milligram per administration is recommended. And it has to be taken with the meal, and if iron and calcium not to be taken concomitantly, and it can be started from the first antenatal care. And the calcium carbonate is the most cost-effective choice. The mechanism of action of calcium is the modulation of the both placental vascularization and systemic vasomotor activity. And the other pharmacological, do not recommend other pharmacological agents like nitric oxide donors or progesterone, diuretics, low molecular weight heparin, metformin, statin, S-omeprazole. These are all not recommended to prevent preeclampsia. And the other nutritional supplements like magnesium, folic acid, antioxidants, fish oil, garlic, these are also not recommended. And dietary salt restriction is also not recommended to prevent preeclampsia. So the only two drugs that have been recommended is the aspirin, low dose aspirin, and the calcium. Thank you.
Sir.
Yes, it's a very informative talk by Dr. Sonalika. The main crux in this is the screening every woman in pregnancy. All the things are available. Only we need to take some time to fill the that FMF screening chart and get the result. This is can be applied to every woman.
Yes. That is a standard way of antenatal care is to offer these things. You may not be doing, but offer. Like aneuploidy screening and preeclampsia, you have to offer to the patient, because preeclampsia can lead to maternal death also, and these people are knowing that it could have been prevented.
Yes.
If it was screen positive, and at least the incidence can be reduced to 62%. That is the study. So it has to be offered, and it can be done along with the aneuploidy screening. That is the other thing. Even if you don't have to do you are not able to do the placental growth factor, at least put on the maternal factors, the mean arterial pressure and the uterine artery Doppler, at least if you add on, and if you are doing the aneuploidy, you can add the PAPI also. The detection rate will be more. And the people who are to be given aspirin is only about 10% of the screen population. And for that, you should not give aspirin just like that to 100% of people unnecessary. Dr. Sonalika, one of the problem now, the thing is that this screening can detect only the early onset preeclampsia, which is only about 30% of the preeclampsia. That is the problem. So that is where our SFLT, PLGF may be detecting the late onset preeclampsia better than the one. And also the late onset preeclampsia cannot be prevented by low dose aspirin. That is another thing. So we may have to do another screening by around 30 or more often. It is recommended to have everybody to have a screen by SFLT PLGF ratio by 35 weeks if you want to, because that detection rate may be more than 10% on that group. The early onset, early screening can pick up only about 2% of it. So that is the limitation early on. And now we have to think of that picking up the major portion of the problem is the late onset, which is around 70%. And mother suffers more than the baby here. Baby might have attained the growth, unlike the other one. There the FIJR is more common. Here, maternal complications are, and suddenly we may have this problem coming up. The patient may develop eclampsia or HELP syndrome. And in our series of maternal mortality survey, I repeatedly present everywhere that we had 50% of the maternal death, they developed eclampsia and died. We could have prevented that death by knowing that they could have been terminated earlier. So also about 30% had a HELP syndrome, death due to HELP syndrome. So we were not able to detect the severity of the disease process by a routine LFT, RFT, BP checkup and other things. And they say if you have the ratio of SFLT and PLGF ratio of more than 85 or 80, And if it is going to 110, immediately you have to terminate. And this ratio disturbance will start 4 to 6 weeks prior to the clinical manifestation of the severe form of the disease. That is the importance. So we have to have. And now the PLGF SFLT ratio is available in our state also. Only thing, it is costly. It is about 2,000 to 2,500 rupees. But if it is worth to save a life. So in suspected cases of, say, headache or a hypertension only, because as we know that last week, a month, we had the MD presentation. We had a patient with eclampsia with a BP almost near normal. So such patient, you can see the severity by this ratio of these biomarkers. So it is coming in a better way. It can be utilized. It is costly, but these are all to be made use of. This scientific knowledge has to be made use of. Thank you. It's a great presentation, Sonalika. Good. You didn't tell your result of the study because we have given only 75 gram, fearing that 150 cannot be given that. It was how many years back?
Sir,
We
6,
studied
5, 6.
5 years.
2018,
Okay,
19.
yeah. We had another girl also doing the same thing. I wanted to know what it is. Again, we were not able to give 100 milligram also. Anyway, there was some reduction, but it was not, number is not much. So, I was not leaving it there. So anyway, very good. Thank you for joining us. Hope we are all doing well. And thank you for my.
Thank you, sir, for the insights, sir.
Thank you.
Thank
Sonalika, it
you.
was a good presentation. Just I want to know, what is the reason for this low PAPE in
Sir, because
preeclampsia?
of the poor placentation, sir, all the pathogenesis is mainly the poor placentation, placental hypoxia. So, so all these are like placental factors, which is released by the cytotrophoblast. So if there is any poor placentation, the PAPE is also reduced.
And how does this low value of PAPE affect the placentation?
It is a reverse. She was telling because of the poor placentation, PAPE and PLGF will be low. That is what she said. I understood that way, isn't it?
Yes, sir.
It is the effect of poor placentation. That is what she said. Yeah.
Actually, the
placentation
bioavailability of insulin-like growth factor is occurring through PAPE. There
Yes, yes, yes,
so that's the site where it works.
Okay, yes, sir.
Yeah.
Yes, sir.
Right.
Yes. Thank you, sir.
If the host is present, can you kindly promote Radha Madam as well as Susan Madam to the panelist session? Host നെക്സസിൻ്റെതാണ് പക്ഷെ അവർ ഓൺ ആക്കിയിട്ട് പോയോന്നൊരു ചെറിയ സംശയമുണ്ട്. മെസ്സേജിന് റിപ്ലൈ ഇല്ല. Radha Madam is in the panelist session and Susan Madam as well. Kindly promote if possible. So without much delay, we go to our next talk. After the preeclampsia, we have optimizing the perinatal outcomes in diabetes. So we have another young charming speaker for the session, Dr. M.A. Binesh from Perintalmanna Society. And to chair the session, we have Dr. Jyoti Chandran. Madam is the HOD of Government Medical College Calicut as well as the immediate past president of Calicut Society. And Madam was vice president of Kfog in 2018 and is the member of state board of ART as well as MTP committee and is a corresponding author of Jogi. And then more than a teacher, Madam still is a passionate, more passionate than a postgraduate in doing all the academic stuff like paper, poster, etc. and winning prizes even now. And along with Madam, we have the secretary of Waynad Society, Dr. Shivakumar S. is obstetrician gynecologist at Sultan Batheri Victory Hospital. Over to the chairpersons to introduce the speaker for the next talk, Dr. M.A. Binesh.
At the onset, good evening, one and all. I would like to thank Kfog for bringing out this Kfog Edge 3 with Maternal Fetal Committee of Kfog and my own society. And today we have something on optimizing perinatal outcome in diabetes by Dr. M.A. Binesh, who is a consultant at Aster MIMS Portugal. She is an alumnus of Calicut and PG from Thrissur, fellow in gynec oncology, fellowship and diploma in minimal access surgery, winner of Best Young Talent Award by Kfog in 2014, presented multiple papers, regional coordinator for Kfog oncological activities, special interest in gynec oncology. On to you, Dr. Emia.
Thank you, Jyoti ma'am. Am I audible, ma'am?
Yes, yes.
Yes.
Thank you, ma'am, for that introduction. First of all, I would like to thank for my opportunity. I am so happy and privileged to be a part of this wonderful webinar. So shall I start screen sharing, madam?
Yes, please. Just make the slideshow.
So the topic that has been given for me today is optimizing perinatal outcome in diabetic
Will not
pregnancy.
slideshow.
Ma'am, it is
So
slideshow.
actually enable first, minimize, and then take share screen. You stop sharing, minimize this particular screen, then take share.
Already shared. It is already shared, madam.
No, madam, actually minimize the screen, go to the Zoom and then again share. Stop sharing first, madam. Please stop share. Top of the. Not that. Yeah, you have to stop the share, top of the screen in the Zoom. Yeah. And now go back to the PowerPoint, make it slideshow, then come back to the Zoom and then slide share again.
Ma'am, is it?
Can you just make the slideshow?
Is it okay?
No, actually the slideshow is not coming, madam. Can you present with the previous window itself?
Okay.
Where you are seeing the slides on the left side, you can present it that slide. That is visible. Yeah, it's okay.
Is it
It's
okay now?
Yeah, okay.
Okay. So, as we all know, diabetes is one of the common medical disorders in pregnancy. It's a rising epidemic, and we have seen an increase in the prevalence of diabetes in India. And the prevalence of diabetes ranges from 3 to 17% all out in different parts of the country. And according to the IDF 2021 data, we can see that 1 in 4 live births are affected by hyperglycemia in pregnancy. And the age-adjusted prevalence of hyperglycemia in pregnancy for Southeast Asia in 2021 was 28%, with number of births affected were appropriately 6.8 million. So FOGSI has come up with the term hyperglycemia in pregnancy, which can be again subdivided into dysglycemia in pregnancy and gestational diabetes. Dysglycemia in pregnancy can be diagnosed using the WHO criteria, that is FBS more than 126, RBS value more than 200 in the presence of hyperglycemic symptoms, and 75 gram OGTT value of more than 200. So if any of the value is positive, then it is dysglycemia in pregnancy. Otherwise, it is gestational diabetes mellitus. So we go to the WHO definition, gestational diabetes mellitus is impaired glucose intolerance with onset or first recognition during pregnancy. And ADA has again classified diabetes into class A1 GDM, which is diet control, and class A2 GDM, which is on medication. So regarding the preconceptional care and counseling, when we get a chance to meet the lady prior to conception, we always should offer her screening for pre-pregnancy diabetes and HbA1c. And if we find that she's a case of over diabetes, then we have to counsel her to maintain normal blood sugar levels before and throughout pregnancy to prevent diabetic embryopathy and vasculopathy. And she needs to maintain the HbA1c less than 6.5% at less than 10 weeks of gestation, because a high HbA1c value less than 10 weeks of gestation is always associated with high incidence of birth defects, congenital anomalies associated with diabetes. If it is more than 10%, the chance of congenital anomaly may be as high as 20 to 25%. So these are all the associated risks with the diabetes, maternal diabetes. We have the maternal risk and we have the fetal risk. In addition to the short-term risk, we do have a long-term complications associated with diabetes for the mother as well as for the baby. For the mother, we have, she is at high risk of developing diabetes in the future. A person who is diagnosed with GDM in pregnancy, 50% of the women who have GDM are supposed to develop diabetes in the next 20 years. And she is also at risk of metabolic syndrome. Similarly, fetus is also at risk of metabolic syndrome and higher chance for developing future diabetes. So regarding the insulin physiology in pregnancy, enhanced insulin sensitivity and lower glucose levels in the first trimester. So in over diabetes mellitus, they may require reduction in the dose of insulin in the first trimester. Around 16 weeks, the insulin resistance begins to increase. The insulin requirement levels off towards the end of third trimester with placental aging. So when we find a sudden fall in the insulin requirement or sudden fall in the blood glucose level towards term, we should think of placental aging. Then that can be a warning sign that the patient can develop an intrauterine fetal demise at that point of time. So we should be vigilant. Normally, the insulin production is sufficient to meet the challenge of this physiological insulin resistance and to maintain normal glucose levels. But in diabetes, hyperglycemia occurs if treatment is not adjusted appropriately. We do have a lot of diagnostic criteria for GDM, and these are certain criteria and their values I have suggested, but I will not be going to all the guidelines because of the paucity of time. So diabetes, India is actually home to diabetes. So we do have a lot of evidence coming from India, Indian studies. So the Indian problem always requires an Indian solution. So we need to stick on to the DIPSI guidelines because there is universal acceptance for the DIPSI guidelines and it is applicable for in the Indian scenario. So just a glimpse on the WHO 2013 criteria, where they have diagnosed diabetes mellitus in pregnancy if one or more of the following criteria met, that is fasting more than 126 to or plasma glucose of more than 200 following to 75 gram of oral glucose load, or RBS more than 200 in the presence of diabetes symptoms. And gestational diabetes mellitus at any time during pregnancy should be based on any one of the following values. This is based upon the IID-PST criteria, where fasting plasma glucose more than 92, 1 hour value more than 180, and 2 hour value of more than 153. So this is the DIPSI criteria. Here we suggest, DIPSI criteria suggest universal screening for all pregnant women should be screened for diabetes. And that is a one-step approach using 75 gram OGTT. That is 75 gram and 2 hour values. 75 gram glucose should be diluted in 300 ml of water and should be taken within 5 to 10 minutes. And she should not vomit in the first 30 minutes after intake of this. And you have to take the blood glucose at 2 hours. If the 2 hour value is more than 200, she should be classified as having diabetes mellitus. If the value is more than 140, she is gestational diabetes mellitus. If it is more than 120 at 2 hours, she is having decreased gestational glucose tolerance. There is another entity called early gestational glucose intolerance, that is less than 10 weeks of gestation. If we do the 75 gram OGTT more than 110 milligram per deciliter, they can be classified as early gestational glucose intolerance. So the advantage of performing the DIPSI guidelines or the DIPSI criteria is the pregnant woman need not be fasting. It causes least disturbance in a pregnant woman's routine activities. It serves as both screening and diagnostic procedure. So it's overall, it's very simple to perform. So this is the universal testing methodology as suggested in the DIPSI guidelines. Pregnant woman coming and we are testing for GDM in the first trimester, or first antenatal visit, or 12 to 16 weeks with 2 hour 75 gram OGTT. If she is normal, the second repeat testing we do at 24 to 28 weeks, where there is maximum chance of insulin resistance, that is 24 to 28 weeks. Again, she is normal. We need to do a repeat testing at 32 to 34 weeks if she belongs to high risk. And if the value is more than 140, she needs to be managed as per guidelines. So the management of pregnant women with GDM, this has been taken from the DIPSI guidelines only. If the pregnant woman is diagnosed with GDM, according to the 75 gram OGTT values, she needs to be initially started on medical nutrition therapy and physical exercise. After 2 weeks of medical nutrition therapy and physical exercise, we measure the 2-hour ppbs value. And if it is more than 120 milligram, then we start on oral antidiabetics or insulin therapy. So regarding the medical nutrition therapy, this is actually a carbohydrate controlled goal directed therapy, which mainly aims at optimal nutrition for the growing fetus as well as for the mother, adequate energy with appropriate weight gain for the mother, with maintenance of normoglycemia. So the dietary reference intake of each nutrients have been suggested, and DIPSI suggests 175 grams of carbohydrate per day, which should account for around 35 to 45% of the total energy intake, 71 grams of protein, which should account for 20 to 25% of the total energy intake. Fat should account for around 25 to 35% of the total energy intake. And the diet should also contain 28 grams of fiber. So we have, how will you calculate the total calories? The calculation can be done using this particular formula, but it's very difficult to use and very cumbersome. So we can depend upon this particular chart, which suggests the calorie intake can be predicted depending upon the level of activity. So in general, we can tell that in the first trimester, she doesn't require any extra calorie requirement. But for the second trimester, 350 kilocalories per day excess. And for the third trimester, 452 kilocalories per day excess. And based upon the BMI also, we can calculate the calorie based upon the formula. And to make it more simple, if she is underweight, you just add 500 kilocalories per day. And if she is obese, you can reduce 500 kilocalories per day. So 70 to 80% of the women will be able to control the glycemic status with medical nutrition therapy alone. So we can also, to make it more simple to the patient, we can suggest this particular thing, the meal plan for a plate of 10 in radius. When you take the plate, the half of the plate should be filled with green leafy vegetables, watery vegetables, or traditional vegetables, whichever is available. And the rest half, quarter of the plate should be filled with proteins, the dal and whole pulses for vegetarians, egg or fish or chicken or mutton or dal or for non-vegetarians. And the rest of the quarter of the plate should be filled with cereals or whole grains or meals. So always complex carbohydrates are preferred to over refined carbohydrates. And it is also preferable to add curd 200 ml for breakfast, lunch and dinner, snacks preferably roasted or boiled Bengal gram and sprouts or salads. So this is a general suggestion which can be applied in the rural health settings. Regarding the exercise always helps in reducing the blood glucose levels. It helps in reducing the insulin resistance. So exercise is always recommended along with medical nutrition therapy in diabetes. So these are certain recommendations. They can be suggested with aerobic exercise, resistance exercise, flexibility, balance exercise, etc. But strenuous exercise activities should be avoided, and performance of an exercise regime should always be discussed with the obstetrician, considering the other obstetric complications also. Then regarding the role of OHA, we can suggest either metformin or glyburide because these are the two drugs which are approved for use in pregnancy. Metformin is category B drug and glyburide is category C. Regarding the use of metformin, Government of India Ministry of Health guidelines suggest metformin to be started after 20 weeks of gestation. And the starting dose is 500 milligram twice daily to a maximum of 2 grams per day. Hypoglycemia and weight gain with metformin are less incomparable to insulin. And if insulin requirement is in high doses, also you can add metformin that will improve the insulin resistance. Because metformin is a biguanide which helps in significantly reducing the insulin resistance. It is not at all a hypoglycemic agent. All over India, this drug is widely used. We do have a lot of trials coming on telling that there are no prominent side effects with metformin use, both short-term as well as long-term. But still, Government of India recommends after 20 weeks only. But DIPSI recommends more than 12 weeks of gestation. If the insulin is not acceptable for the patient, then you can opt giving metformin after telling the pros and cons. The problem with metformin or OHA is they will cross the placenta and they can be secreted in the breast milk. Then the other drug which you can use is glyburide, 2.5 sulfonylurea, 2.5 to 20 milligram in divided doses. The dose increment weekly up to 30 milligram may be necessary to obtain glycemic control, but long-term outcome studies also still lacking. So insulin is always the standard of care for the management of diabetes. It is the standard of care always in over diabetes. Somebody on over diabetes already on OHA should be switched on over to insulin once she is diagnosed with pregnancy. So the factors predicting the need for insulin are presence of macrosomia, higher baseline HbA1c value, older age of diagnosis, past history of GDM, hydramnios, higher FBG of more than 110, ppbs of more than 140, elevated BMI. So all complicated diabetes should be always treated with insulin. So where will you administer insulin? Insulin can be administered in all the shown sites. As you can see, it is always better absorbed if given on the abdominal wall. But in the later trimesters of pregnancy, if they find it difficult to administer on the abdominal wall, you can advise her to administer insulin in all these recommended areas in the upper outer arms, in the anterolateral aspect of the thigh, in the buttocks, etc. Then regarding the insulin regime, none of the insulin regimes have been found to be superior or inferior, or none has been found one over the other. The insulin regime has to be individualized, and that depends upon the patient blood sugar values. Always, the standard of care is intensive self-monitoring of blood glucose with all 3 pre-meal and 2-hour post-meal glucose test. So always a 7-point testing is the gold standard for monitoring the blood sugar levels. But DIPSI guidelines suggest at least 4-point testing should be done. That is FBS and 3 post-meal values. That will better help in assessing the blood glucose level and better control using the insulin. Starting dose of insulin should be 4 units subcutaneously, and ACOG recommends 0.7 to 1 units per kilogram per day as the starting dose also. And the dose should be titrated based upon the blood glucose values, and it can be used until the target value is reached. So daily self-blood glucose monitoring is always recommended. Basal bolus insulin regime is preferred in pre-gestational diabetes mellitus. That is pre-meal regular or rapid-acting insulin and bedtime basal insulin, because that gives a better control of the blood sugar values. So we do also we should, if acceptable or affordable for the patient, we should suggest them continuous blood glucose monitoring, because it gives a better idea about the glucose profile of that patient. So these are the different types of insulin that we have. We can see that majority of them belong to the category C. Only for insulin glulicine, degludec, and insulin glargine have been shown under category C. But insulin glargine, regarding insulin glargine, many of the patients might be on insulin glargine if they are already over diabetic patients, and if the diabetes is well controlled, it's very well that they can continue this glargine throughout pregnancy, because not major safety concerns have been issued. And regarding the insulin therapy, the DIPSI guidelines suggest it is ideal to use human insulins, which are least immunogenic, and rapid-acting insulin like Aspart and Lispro have been found to be safe and effective in achieving the targeted postprandial glucose value during pregnancy. And the RSSDI 2022 suggests insulin is the first-line treatment recommended for all pregnant women with pre-GDM. Basal bolus therapy is the most effective in helping achieving these tight glycemic targets. All human insulins are safe in pregnancy. Insulin Aspart and Lispro are approved for use in pregnancy, although we have sufficient data on glulicine, and insulin insufficient data on glulicine. Insulin detamar has been approved for use in pregnancy. So what are the targets that should be achieved while a patient is on any form of therapy in pregnancy? HbA1c should be less than 6. For pre-pregnancy, it is less than 6.5. For during pregnancy, on treatment should be less than 6. And fasting glucose should be less than 90. Postprandial less than 1 hour value less than 140, and 2 hour value should be less than 120. For the limited care settings, the management of GDM as suggested by the DIPSI guidelines is according to this chart. The pregnant woman with GDM has tried medical nutrition therapy for the first 2 weeks. The postprandial blood glucose 2 hour value is more than 120, then we can start human insulin, or metformin if she's more than 20 weeks. How will you start insulin? They suggest mixed-start insulin as subcutaneous regime 30 minutes before breakfast as OD dose, and the dose of insulin can be easily calculated by the blood sugar levels as given in this particular chart. And after that, we monitor the FBS and PPBS every 3 days. If FBS PPBS is normal, that is less than 90 and less than 120, we can continue the same dose of insulin. But if the PPBS value is more than 120 and FBS is normal or less than 90, then we need to increase the morning dose by 2 units. But if both are high, then we need to add 4 units pre-breakfast and 2 units pre-dinner. And then we monitor every 3 days. Ideally, self-blood glucose monitoring should be the standard of care. But in limited care settings, if you have to monitor frequently every 3 days, once the blood glucose controls are achieved, then we may do it more infrequently. So this is the summary of evidence from an Indian experience. It's based upon the CME presented in the CME India repository, March 2024. So they have suggested insulin is the drug of choice. Injection human premix insulin 3070 is to be administered according to MOH Government of India guidelines for the limited care settings, because basal bolus regime seems more complicated. Insulin analogs present undoubted advantages in reducing hypoglycemia and promoting more physiological glycemic profile. Insulin glargine can be safely continued in pregnancy if they are already on, and basal insulin analogs are not inferior to basal insulin. So regarding the antenatal care, because the GDM is a high-risk pregnancy, we need to follow all the high-risk pregnancy protocols. Apart from the routine antenatal care, we need to have a continuous, we need to have a more vigilant monitoring, both for the mother as well as a fetus. We need to do all the scans, and for overt diabetes, we may offer a fetal echo at 20 to 24 weeks because to rule out the possibility of congenital heart disease consequent to an uncontrolled overt diabetes. And strict DFMC should be advised, at least 3 kicks in 1 hour or 12 kicks in 10 to 12 kicks in 12 hours. And we have to monitor for abnormal fetal growth, macrosomia, which is associated with GDM, and overt diabetes with vasculopathy may be associated with the IUGR. So fetal growth needs to be monitored, polyhydramnios at each antenatal visit. And again, we have to monitor for hypertension because especially in overt diabetes, they are at high risk for developing severe preeclampsia. Check for proteinuria and other obstetric complications. Then regarding the management of overt diabetes, switch over to insulin. Always the basal bolus insulin regime is the best, and they have to do the continuous monitoring. Timely screening for diabetic complications is crucial. We need to do the HbA1c, creatinine, urine albumin to creatinine ratio. If the creatinine is found to be more than 1.4 and the daily protein excretion is more than 2 grams per day, we have to consult with a nephrologist, and it needs to be managed accordingly. Because mild nephropathy usually may not worsen during pregnancy, but moderate to severe nephropathy can worsen during pregnancy, and there is a high risk of developing severe preeclampsia. And she needs to do regular retinal examination. She needs to be offered retinal examination at the first visit, and it needs to be repeated at 28 weeks. If anything abnormality is found, we have to consult with the ophthalmologist, and you may advise laser ablation if required. And special attention should be paid to review the medication. Sometimes she might be on ACE inhibitors, statins, etc. So all those medications should be reviewed. And if anything is found to be teratogenic, you have to change accordingly. And regarding the role of steroids, as per the Government of India guidelines, steroids needs to be administered between 24 to 34 weeks of gestation. If you are anticipating an early delivery consequent to another obstetric complication intervening like severe preeclampsia, IUGR, abnormal Doppler, etc., we can give injection dexamethasone 6 milligram IM 12th hourly for 2 days. But more vigilant monitoring of blood sugar levels with insulin dose adjustment should be there for the next 5 days. Regarding the timing of delivery, well-controlled diabetes at or after 39 weeks. ACOG recommends for patients who are on medical nutrition therapy, they need to they can continue till 40 weeks 6 days gestation. But Government of India or DIPSI guidelines recommends don't go beyond past date for a patient with diabetes. And in uncontrolled diabetes, the timing of delivery needs to be individualized. Ideally, it should be after 37 weeks only, unless there are some other additional complications which mandate early delivery. And the diabetic pregnancy should be managed in higher centers if she is having uncontrolled blood sugar levels or the insulin requirement is more than 20 units per day. Always vaginal delivery is preferred unless there are other obstetric indications. And if baby is more than 4 kg, elective LSES should be done at 39 weeks. Regarding the intrapartum care, the morning dose of insulin or metformin is withheld on the day of induction or labor. 2-hourly monitoring of blood glucose, blood sugar should be done. And based upon this particular chart, it is very easy to monitor the blood sugar and administer the insulin infusion. IV infusion with normal saline is to be started and regular insulin to be added according to the blood sugar levels as per the table. If the blood sugar level is less than 70, we need to add 5% dextrose. Then about the care of newborn, early breastfeeding is always advocated to reduce the chance of hypoglycemia. Blood sugar monitoring is always recommended within 1 hour after delivery and every 4 hours prior to next feed till 4 stable values, glucose values are obtained. And we have to start treatment if hypoglycemia is diagnosed, that is less than 45 milligram in normal baby and less than 54 in IUGR. The neonate should also be evaluated for other neonatal complications like respiratory distress syndrome, convulsions, hyperbilirubinemia, etc. Symptoms of hypoglycemia are very variable and they are seen only in a very small proportion of the patients. Regarding the postpartum care, OGTT should be repeated at 6 weeks after delivery, then annually. If somebody is on insulin, high dose insulin, then we may do a blood glucose monitoring 1 to 3 days postpartum. Otherwise, if she's on medical nutrition therapy or well-controlled GDM, then she needs to repeat an OGTT at 6 weeks after delivery. ACOG recommends performance of OGTT at 4 to 12 weeks after delivery. DIPSI guidelines themselves, they have suggested suggested that the performance of an OGTT within 2 days after delivery might have a similar diagnostic accuracy in predicting future diabetes compared to the 6 week performance at 4 to 12 weeks after delivery. So, but that have not come in the guidelines. As of now, OGTT should be repeated at 6 weeks after delivery. And we need to counsel about the lifestyle modifications, weight monitoring, exercise, family planning. And for pre-GDM on insulin, dose reduction of 20 to 40% might be possible in the postpartum. So with that, I conclude. I hope that I have covered almost all the aspects of GDM in this particular short period of time. So thank you.
Thank you, Dr. Remia, for that comprehensive presentation. Just wanted to add a few more points. One is that the dosage calculation, actually it's a titration. With experience, we get into titrate the dose of insulin, but if you want to depend on the formula, it is 0.7 for first trimester, 0.8 and 0.9 per unit per kg body weight. And even you have the new insulins, which are working better and with the better glycemic control. And definitely in labor, we should also be on the lookout for shoulder dystocia.
Yes, yes,
and in most of the conditions, we have never, laboring women very rarely needs insulin. And concept trial came in 2017 where they told about continuous glucose monitoring in type 1 diabetes. So they found that if the woman is having type 1 diabetes, she should go for continuous glucose monitoring. Yes. And obviously the neonatal care, when the baby should be watched for signs of hypoglycemia and given glucose timely, and the neonatal complications should be looked into. Thank you so much.
Yes, ma'am. Thank you.
Remy, it was a vast coverage of GDM and diabetes, but I have got so many doubts. First of all,
stop sharing. Share screen. Yeah.
First of all, I want to know how you said you will start with exercise, medical nutritional therapy, and then you will change. Is it not? For after 2 weeks.
Yes.
In case of GDM, by this time, if the patient is having hyperglycemia, baby will have the imprinting occurring. So you won't be able to prevent the recurrence of this disease in the society. One. Second thing, if you are giving, how many percentage of patients with oral hypoglycemic agent you can get a control? You may have to add minimum of 50% of patients you will have to add on insulin. So why not insulin start with and then you go with other drugs? Then another thing regarding OGTT at the 6 weeks postpartum, what additional benefit you are getting by that?
Just we can, if it is still high, then
no. See, if the patient is having GDM, that means this patient is destined to develop diabetes, is it not, in the future? Yes, that you are getting nothing by doing GTT. You just do fasting and postprandial, and you just want to know whether she is a pre-diabetic or GDM. That's all.
Yes.
There's absolutely no use for doing OGTT at 6 weeks postpartum.
Yes, sir. Yes, sir.
Another thing, in our population, DIPSI will not work because we are not getting the fasting value.
DIPSI doesn't require.
It doesn't require, ma'am. Only 2 hours 75 gram OGTT.
Again, regarding the single step, how many steps you have to do? First trimester, second trimester, third trimester. Is it not? So many steps. If you go by 2 steps, you will have to do at least 1 and then 3. Is it not? Just for 4 pricks is enough.
And now the incidence of diabetes is increasing to 30-35. We are now having every other patient in our college is having diabetes.
So you are living in Western standard.
It's
So I
okay.
would,
There is
I would say
no,
the
we
most
have to
important.
especially yes, yes, please. Continue, Lakshmi.
No, sir, you please continue. I'll talk after you.
No, it's okay. No, there are students also logged in. So the dosage, the mixture, there are actually the plain as well as the intermediate. The plain one will start acting within half an hour, last for about 3 hours, and the other one, intermediate one, will start acting at 3 hours, and it may last for 6 to 8 hours. That is the rationale in taking 2 injections of this mixture, the 30-70, 2 injections may be okay. The dosage calculation given in the textbooks and other things, if you think of that 0.7 per kilogram body weight, if somebody is 50 kilogram, what is the starting dose you are recommending? It will be 35 units. You don't require that. It is there in the books. That is unfortunate, I think. Can you start with the 35 units in a 50 kg one? Isn't it? 0.7 per kilogram body weight. That is the dosage given. And it may not be required that much. We have to schedule. You said starting point maybe 6 or 8 like that. You work up for a particular patient. So this formula, I don't know, it is all there in that textbooks and international books also. Do you just really calculate that way? I
So,
don't
ma'am,
think we will start with the 35 units.
Sir, if we start with, if we go with DIPSI guidelines, then it would be better. They recommend
That may
starting
be.
2 units, 2 units like that.
I think we must forget about this 0.7 unit per kg. It will come to just 50 kg will come to 35 units to start with. We may not require that in a GDM. As Vinayan was telling, it is better that to have a proper control of diabetes should be insulin. I believe so. But to avoid so many number of injections and patient's preference, we have to give oral also, I mean, metformin. And it is found to be effective without any other problem. So we have to adjust it if it is getting controlled. Why metformin is a good option, but usually I'll be always giving insulin for any diabetic, whether GDM or otherwise. But because the absorption may be erratic, especially in the earlier period. If it is pre-diabetic, then you may have to, as you said, you have to have insulin only, not this. So there are conditions what you have mentioned where insulin has to be started. Very well, that is the way to then. DIPSI is okay for our this thing, and all the students who may be listening, you should at least know the DIPSI guideline. The other one, that 3 values, you may pick up more cases because it includes fasting the 1 hour as well as the 2 hour. You may get more, but you may not miss the diabetes, which is a test which is showing negative value in the early period. You have to repeat it at 24-28 weeks, and even if it is negative, again 34 weeks, because GDM may develop at the 3rd trimester or later weeks of birth. So we have to repeat the test, even if it is negative, as you have said. It is the way. At least 3 times you have to test. Not only stopping at 24-28 weeks, but also go on to 34 weeks, so that you may not miss, because it can be seen as late as 30 to 34 weeks.
Just wanted to add 2 points. Diabetes has a very alarming increase in our society. It's almost like an epidemic. So 2 important things.
Yes.
One is to strictly do a universal screening. We do not do a selective screening. It should be a universal screening. And the other thing which you rightly mentioned is we are so liberal with the use of antenatal corticosteroids. So when you give steroids in a diabetic patient, strict glucose monitoring for the next 5 to 7 days is mandatory, because that can sometimes precipitate an intrauterine fetal demise, which we have seen in our cases. So that should strictly be followed.
Another thing is unnecessarily steroid should not be given also.
For the diabetic patient.
Ambuja madam is please unmute.
I'm for screening in the 3rd trimester also, because another 13% is diagnosed in the 3rd trimester. And when we diagnose it in the 3rd trimester, we can have intense monitoring, glucose monitoring. Otherwise, we might miss, and we might actually end up with an unexplained intrauterine death also. So 3rd trimester screening, we are doing it routinely at 32 to 34 weeks. And then another thing is our first line management has been always metformin. And if it is not controlled with metformin, then only insulin.
For me, it is insulin only.
At least in the 3rd trimester, it should definitely be insulin, close to 3rd trimester.
The main
one
problem with the metformin is you have to wait for another so many weeks and then say it is not controlled. Then you change. So if you give insulin, you will get controlled.
No, the acceptance of the patient has to be considered. If
Yes.
take your own condition. If you have to take 2 injections per day, if I can avoid that without much problem, I will opt for that. So
But
that
see,
is how the metformin has become very
but if
popular and
sir,
without much of a problem. It is
but
getting
if you tell
controlled.
to the patient that your baby is also likely to develop this condition, if you are not taking this insulin, then they will accept insulin far more than the drug.
No. Metformin will not produce that way. Well, the control may not be very good, but it is
around
shown by many studies.
40 to 50% of patients has to have insulin, even if they are on metformin. Is it not?
No. A nice body is like nice. When they recommend metformin for control of diabetes in pregnancy, we cannot say no to it. But it is our preference to have a proper control. As I said, I used to give only insulin.
Yes.
But I know that it has to be the patient's concurrence also. And such a body like a nice is promoting that. So we have to accept there is scientific basis for that. So
Again, sir, you just asked the nice what they are getting by doing the OGTT at 6 weeks. They don't have any
we
answer.
will be doing first visit. First visit. There is no this thing. First
Just
visit has to do something.
Just fasting and postnatal is enough, sir. The other one is food that she is going to descend develop.
No, we are not. We have to have certain standard. The students are to follow certain standards, and our experience also counts as we become seniors. But for the students and juniors, we have to follow the standard way. One is at least you should know what is dipsy. You should know what is the normal way. I am talking to my students only.
Agreed, sir. But I am saying that don't believe all these things from the Western side. They are the dictators and say that they say, so we have to accept it. Sorry.
No.
For the exams, they have to say. For the exams, they have to say.
Exam. For the getting exam, they will have to have pass. For that pass, they will have to say all these things. Just I want to say my point of view. That's all.
That is true. I am also with you. But for the students' sake, I said they should know what is dipsy. They should know why the NICE is telling all those things. So that is why. So there is a place for metformin. Glyburide and other things we are not having an experience. It is sulfonylurea only. But there was initial study for oral hypoglycemic agents were on glyburide only. That is how it has come.
Sir, anybody using glyburide?
They were all having that congenital anomalies were due to the severity of the diabetes at that time, not because of the drug. That is the study result. The congenital anomaly associated with oral hypoglycemic agents and fear created. Actually, the cases were severe diabetic patients were given oral hypoglycemic agent. They had more of congenital anomaly and it was transferred to the drug. Now, later on, it was proved wrong. So there are so many facts about the diabetes. It has to be screening, as we said, once, twice, thrice. So 3 screening.
Anybody using glyburide, sir?
No. I said initial studies.
Ambuja Madam Rajagiri using glyburide?
No, we are not using glyburide.
No, metformin is not bad.
Metformin.
So it's a good discussion. Dr. Ramya, very well presented. We have to see you more often. Than hiding somewhere. We are having a lot of programs in Kfog and in societies. So we want to see you more often. Okay?
Yes, sir.
Thank you. Not only
Thank you. Actually, we are running late of schedule.
So the night is so long, man. The night is all there.
No, sir, I have to go. No, sir, I have to go.
Okay, last one.
So we'll go to last session.
Unmuted.
So to chair the session, we have Professor Vinayendran sir, Professor and Unit Chief of MMC Medical College, and former professor at Government Medical College, Calicut, as well as Pariyaram, and was past president of Kfog as well as Cox. Welcome you, sir. Along with sir, we have Dr. Jayalakshmi Suraj, who is diploma in gynec endoscopy from Kiel, Germany, and trained in reproductive medicine, and is the director of the Dreamflower IVF Center, Kasargod. And to talk on the topic of Doppler in obstetrics, we have Dr. Archana Sudhir. I request chairpersons to introduce the speaker.
Dr. Archana Sudhir is having fellowship in fetal medicine from CIMAR Cochin or Edapar, 2017, and undergone neurosonography masterclass from FMF UK, and consultant in fetal medicine, ARMC Kannur and Astraya Hospital, Maternal. And over to you, Archana, so that we can hear from you what is in store for us.
Thank you, sir. Thank you, Kfog, for giving me an opportunity to speak today. I'll share my screen. So my topic for today is Dopplers and fetal growth restriction. So as we all know, fetal growth restriction is basically the inability of a fetus to attain its growth potential. So why do we need to identify them? From the beginning onwards, we'll be actually monitoring them. During every antenatal visit, we are actually monitoring them to see for there is any signs of growth restriction. So why do we need to identify them? So then basically we need to give them healthy babies like this and not very sick babies like these who are acidotic and who are having a very high NICU stay. So basically we identify IUGR or fetal growth restriction to improve the outcome. So next is how do we identify them? So basically it is by predictors. In the first trimester only we have the predictors. During the NT scan, we can just put on our Dopplers and see for the uterine artery, that is a mean uterine artery PI. If it is high, it's a predictor for preeclampsia as well as growth restriction. Then when we do combined screening, we can also see for the Papae levels. If the Papae levels is very low, that is also an indication of low placentation, and therefore there is an increased risk of preeclampsia as well as growth restriction. PLGF is also an indicator for the same. And then during our routine examination, we'll be doing our abdominal examination, symphysis funnel height will be monitored. Along with that, we'll be plotting the growth charts to find out whether there is any reduction in the growth. So basically, when we identify a fetus with growth restriction, basically we have to follow a growth chart so that we can see for the interval growth whether the baby is actually growing normally or not. And secondly, we'll be using Dopplers. So the common Dopplers which we normally use for not only for identifying, for prognosticating as well as monitoring the fetuses are basically the umbilical artery, the MCA Doppler. Aortic isthmus is actually not much used in prognosticating or managing these. This is just still under research. Then the ductus venosus comes into play. So basically, all these Dopplers act hand in hand to help us in making in managing these babies with fetal growth restriction and taking a right decision at the right time. So basically, there are two types of IUGR. One is early onset IUGR, as we know that it's usually less than 32 weeks, and late onset IUGR, which is more than 32 weeks. It is not exactly 32 weeks. It can overlap slightly here and there. And early onset IUGR, as we all know, that it actually follows a cascade. There is placental implantation, trophoblastic invasion. So there is increased uterine artery PI followed by umbilical changes. Then there'll be DV changes, and then finally there'll be imminent death of the fetus. So that is it follows a stepwise pattern. Whereas in late onset IUGR, which usually presents in the later gestation, that is mostly after 32 weeks, the baby will be growing normally, and suddenly it's like falling from a tree. Suddenly there'll be suddenly everything drops down. So that is what happens. I'll be coming into the detail of it. So basically, there are two types of IUGR I've already told. So In early onset IUGR, it's very easy to diagnose because the weight is very low. The Dopplers will be changing. So diagnosis is very easy for these babies. But the problem with us is prematurity because we'll have to deliver. Most of the times it will be identified very early. And the thing is whether we should deliver or not is our question. Whereas in the late onset IUGR, it is very difficult to diagnose. It usually happens very late. It may be even diagnosed at 36, 37 weeks. So by then, it is the main thing what we need is we need to identify them so that we can deliver them early. Here, prematurity may not be a problem. It's basically diagnosing becomes a problem in these cases. So as I've already told, the early onset IUGR, it is first there will be placental disease, there will be fetal hypoxia, then the baby goes in for suspicion of acidosis and finally acidosis, and finally there is imminent death. So this progression or this stepwise that travel of the fetus, it almost takes around 28 days. That is around 1 month it will take for the progression. So we can actually, when we see an early onset IUGR baby, we can approximately tell which is the time which they'll need a delivery on. And depending upon that, we can prognosticate what is exactly the prognosis of the baby. So the diagnosis is very early. Basically, it is prematurity which makes it a problem. So as we have already been discussing that there is a problem with the trophoblastic invasion. So when the trophoblastic invasion does not happen properly and there is thrombosis of the end arterioles, what happens is the flow across the umbilical artery does not happen like normal. There should be, this is the umbilical artery Doppler. Here we can see that during diastole as well as in systole, the flow will be a forward flow should be there, which is a very low impedance flow. So when there is a resistance in the placenta, what happens is this the flow becomes more and more resistant, and thereby this will be shown in the umbilical artery. So here there will be usually as the obliteration of the tertiary villi increases, there will be still more and more resistance against which it has to flow. So this will result in end diastolic flow reduces, and this will be there will be changes, severe changes in the umbilical artery, which is indicative of fetal hypoxia. So once a placental abnormality happens, then there will be hypoxia, and then it will go for acidosis. Baby will go for acidosis. So how do we measure an umbilical artery? Basically, we need to identify a pre-loop of cord, and then we switch on the color Doppler. We use a pulse Doppler. A good vessel should be taken, and basic things which we need to see when we are sampling an umbilical artery is one is fetal breathing. If there is fetal breathing or maternal breathing, there can be abnormal readings. And whenever when we get a high resistance flow, just wait, ask the patient to hold her breath and see whether there are no movements or any hiccups. And then we sample it, and the area of least resistance of the umbilical artery should be taken into consideration for prognosticating or managing these fetuses. So as we all know, this is the Barcelona criteria which we commonly follow for classifying the types of groups of IUGR. So basically, we have 4 types of intrauterine growth restriction. First one is placental insufficiency. That is mild variety, which is characterized by there is the estimated fetal weight will be low. Along with that, umbilical artery PI will be high. So in this, we have almost around 4 weeks of time for the baby to actually become bad. So we can monitor them weekly. Whereas as the placental insufficiency still increases or it becomes more severely hypoxic, there will be absent end diastolic flow in the umbilical artery. But still, till then, when the baby is only hypoxic, the DVPI will always be normal. So in these cases, what we need to do is we need bi-weekly, that is twice a week, we need to call them back. Then third stage and fourth stage is actually the baby's baby is trying to push all its force to push pump against the high resistance flow, and finally the baby's heart starts failing, which is shown by changes in the DVPI. So once the DVPI increases, then we have to be very alert because there is a high chance of acidosis, and when the baby is around less than 32 weeks, that is the indication for delivery. So this looks like a complicated chart. The 2 basic things are, one is we have to see the cutoff as 30 to 32 weeks. And before 32 weeks, ductus venosus changes is an indication for delivery. And after 32 weeks, it's the umbilical artery absent diastolic flow, which is the indication of delivery till 34 weeks. And any IUGR baby, when we have a severely IUGR or when there is an umbilical artery is high resistance flow, that is basically mild hypoxic babies, we can monitor them and wait till 37 completed weeks for delivery. Coming to the late onset IUGR, which is mostly unidentified in most of the cases. Here, these babies usually will be identified usually after 32 weeks of gestation. Most of the times, the babies are not actually small. The baby may not be less than 3rd centile or less than 10th centile when we see them. But when we see the growth chart, there will be a constant fall in the growth. Once it has attained a gestation, then when we see the growth chart, there will be a sudden fall in it. That should be taken into consideration. Umbilical PI in these cases will also be normal in most of the cases. And by the time the umbilical PI changes or the baby becomes severely baby becomes a little small, the baby would have actually crossed 36 to 37 weeks for the weight to actually reduce less than 10th centile or 3rd centile. So many times it may not be picked up at 32 weeks. So we have to always look at the growth chart to identify these fetuses. Next is abnormal CPR ratio or the cerebroplacental ratio. So when we see umbilical artery PI will be slightly on the higher side, but it's still within the normal range. Vasodilatation in the brain vasodilatation will be there. That is middle cerebral artery vasodilatation is there. Together when we combine, we see the CPR ratio. So umbilical artery PI is a little on the higher side. MCPI is very low. This gives an abnormal CPR, which is one of the indicators of late onset IUGR. And second thing is, as I've already mentioned, there is a fall in the growth curve. So this is the criteria for identifying the late onset as well as the early onset IUGR. So early onset IUGR late onset IUGR may not have such huge growth restriction. So the baby may be like at anomaly scan, you would have had a good weight, that is around 70th centile. And the baby has become 20th centile. That is, it has reduced by 50th centiles. That shows that there is a late onset IUGR. That is itself telling that there is a late onset IUGR. But when we see only the growth chart at that time, or only the growth centile at that time, we may not identify this. So I'll just put in a few cases so that it'll be easier for us. So first is a case one. This lady comes to us with a 24-year-old lady. She comes, she's a primigravida with a BMI of 22. She comes for a routine NT scan. No medical history. In NT scan, we see that both the uterine arteries are like this. So there is a high resistance flow in the uterine artery, and we always take the PI value in this. And then we do a scan, otherwise it's normal. There are no major anomalies. The NT is normal. Everything else looks fine. Combined screening also shows a low PAPA. So now we have to be alert. There is uterine artery PI high. The PAPA is also low. So what do we do now? We actually tell them there is an increased risk of preeclampsia as well as IUGR developing. So like preeclampsia, if we start ecosprin in these, we can reduce the risk of IUGR as well as preeclampsia, that is 150 milligrams HS, will reduce the risk of IUGR by around 70% when it is developing, at least the early onset IUGR will be reduced by around 70%. Coming to a second case, which is a 37-year-old ICSI conception. She comes for routine NT scan, uterine artery PI is high. Otherwise, everything else was normal. We call her up. Again, she comes for anomaly scan. Anomaly scan, then at 22 weeks, she comes. So the growth is actually estimated fetal weight is very low. It is less than 3rd centile. Umbilical artery PI is absent, shows absent diastolic flow. Now we are alert. So when there is absent and diastolic flow, it is indicative of severe hypoxia for the fetus. DVPI is normal. That means that the heart is not failing. So the baby, she falls under stage 2 category of Barcelona. This is her chart. So now, like I have told, she comes into the stage 2 category. So how do we counsel them? So now after when she's in stage 2, we have almost 21 days for her to deliver. So we have to tell them regarding what are the possibilities of what are the complications of prematurity which the baby might have to face due to early delivery, and the parents as well as obstetrician should be prepared for early delivery and all the problems related to it. Coming to case 3, which is a 22-year-old primary gravida with no significant past history. She comes at 26 weeks with some abdominal pain, and then when we do a scan, the estimated fetal weight was less than 10 centile, uterine artery PI is high, umbilical artery PI is high, GVPI is normal. So umbilical artery PI is high, estimated fetal weight is less than 10 centile, she comes under stage 1 category. And with GVPI normal, we know that the heart is okay. So now we plotted on a graph. So the estimated fetal weight during the anomaly scan was 28 centile. Now it has actually dropped to 8th centile at 26 weeks. So this is still stage 1 surveillance, stage 1. So we have to tell, what all we need to tell them is, one is we have to call them weekly because there is a high chance it will further progress. Severe hypoxia can come and which can finally lead to acidosis. So we have to tell her to be careful regarding her daily fetal movement count and call her for a weekly surveillance. Next is case 4, which is again a 22-year-old primary gravida with no previous history. She comes and anomaly scan, growth is around 10th centile. All Dopplers are normal. Uterine artery, umbilical, everything is normal. So this is we are a little worried because the weight is actually everything. All the dates were checked. Everything is okay, but the weight was actually low, less than 10 centile. So I call her up after 2 weeks. Again, it's actually like it is. Then we can see this graph, which shows that it's following a trend. It's actually growing slowly, but it's a constitutionally small baby. So when we plotted on the growth, and the growth is actually proportionately the baby is growing, then it's okay. We call it STA fetus. So basically, in such cases, we need to see for the interval growth. Basically, fortnightly surveillance is what is required. And if everything is normal and she does not go in for further IUGR, there is no Doppler changes, we can deliver her around 40 weeks. But we need surveillance for these fetuses because many times these SDA fetuses can slowly overlap into FGR with Doppler changes. Case 5 is a 34-year-old lady. She is a G2P1L1, no past history. Growth scan, everything was anomaly. Growth was normal and no other anomalies were there. At 32 weeks, she comes to us with growth of 15 centile. So we know that from 60th, it has dropped to 15 centile. Now we should be alert. Uterine artery is PI is high at the time. Umbilical artery is normal. MCA shows mild vasodilatation. So MCA vasodilated, umbilical artery is normal. When we combine together and do the CPR, it's slightly on the lower side. BPP is good. So now we know that when we see the BPP, that is biphysical profile, that is the fetal movements of fetal breathing, we are happy that the brainstem is actually functioning good. When the brain, this fetus is actually a late on. There is a pollen growth curve. So this is actually late onset IUGR. So now what do we do next? The baby is moving well. So first we need to tell them that there is a high chance of reduced fetal movement. The baby is having some degree of IUGR. So the patient has to keep a good fetal movement count. We have to give them a chart regarding the movement how movement to be monitored, and call them up after 1 week. Because there is some of these fetuses with late onset IUGR will be suddenly intolerant to this hypoxia, sudden onset of hypoxia, and this can result in brainstem suppression. So when brainstem suppression, there can be sudden IUD. So we have to tell them to be careful regarding that. Along with that, we have to do NST, because if there is a good variability in NST and breathing movements are good, fetal movements are good, we can wait. So do we rely only on the umbilical artery to decide the timing of delivery? The answer is no. We need to look at CPR ratio also. Along with that, we need to see for the fetal movement, which is actually a very important factor. Many times the patients will think the scan is normal, so we'll wait for some more time. But brainstem suppression can happen suddenly. So whenever there is a reduction in the fetal movement, they should report back. So what I have told, that is a fetal breathing, fetal tone as well as fetal movement is highly indicative of a good healthy baby. So when there is a fall in growth curve and we don't identify them and directly, you call them up, do not do a scan at weekly surveillance and call them up around 37, 38 weeks. There may be high chances of the baby having a sudden hypoxia, which will result in IUD. This is one of the most common cause of unexplained IUDs, which are happening in late babies who are not very small. So take-home messages are basically in early onset IUGR, we can follow the Barcelona criteria, because here it will follow that stepwise pattern. But in late onset IUGR, we should always keep our minds open to identify them. Along with that, we should tell them regarding importance of fetal movements, take NST as well as monitor them with fetal breathing as well, and CPR ratios. And timely delivery is a key for such babies. At least if we diagnose late onset IUGR, we find there is an abnormality in the growth, deliver them at 37, 38 weeks, we will reduce the risk of stillbirth by around 50% due to late onset IUGR. Thank you.
Thank you, Archana, for the informative talk.
Thank you, ma'am.
Just to add, always rule out congenital anomalies before diagnosing IUGR. And first, distinguish between SGA and the pathological IUGR. Those 2 points.
I would just like to know that one case scenario you presented with the IVF pregnancy, 22-weeker,
Yes.
with the uterine artery, umbilical artery, SD ratio absent. How often you see that patient?
Actually, absent diastolic flow needs bi-weekly surveillance, but it's at 22 weeks. We may not be able to intervene actually at 22 weeks. So I call them usually after at least after 10 days or 1 week.
By that time, doctors will become abnormal, is it not?
Because at 22 weeks, even if we deliver them, there is no, it's actually increasing the anxiety for the patient. Every 2 weeks, 2 days, 2 days if we call her.
Yeah, I mean, problem is, I mean, at 24 weeks, whether you be able to, with the ductus venosus reversal, survival.
That's what we need to tell them regarding all these things could happen. There is a high chance that the baby can go in for an intrauterine death only. So depending upon what they need, like if they are willing for a very high, like going for a very intensive management or NICU care, then we can go for a very admit them and see for go for an entry surveillance and deliver a very preterm baby. But the considering all the morbidity as well as the
risk for the preterm and all the
complications as well as the neurological problems, everything. Like we need to tell them, and it depends upon their choice as to.
Yes, you'll have to counsel and then come out with the real reason and then go for it. Okay, it was good. Thank you.
Thank you.
Thank you. By that, we come to the end of the session. I kindly invite Ambuja Madam for the final words.
Ambujam, Swiggy order ചെയ്തിട്ടുണ്ടോ ഞങ്ങൾക്കെല്ലാം?
Swiggy order ചെയ്തിട്ടുണ്ട്, വന്നാ തരാം. Anyway, it was a very nice evening. We had all the youngsters speaking, and they were all coming out with all the latest guidelines and all that.
അത് എന്നെ ശേഖരൻ സാറിനെ ഉദ്ദേശിച്ചാണോ?
അതിലും പ്രായം കുറഞ്ഞവർ.
Very nice to see all the youngsters shining. So thank you very much for joining, and thank you speakers and all the chairpersons and Shekharan sir, Omana madam and everyone. It was a wonderful session.
Thank you.
Thank you.
Thank you. Good night.
Thank you all once again. So I think we can wind up the session. Good night, everyone.
Good night. Good night.
Thank you.
Good night ആണോ നാളെ പറയാം.
Good night.
Okay, thank you.
Good night. രജീഷ് നീ നാളെ ഉണ്ടോ? രജീഷ് പോയോ?